welcome to the Dundee IJB meeting of the Wednesday 13th of December, and a Merry Christmas to everybody if I don't get a chance to say that in the course of our very busy agenda. I'm going to hand over to Arlene for apologies, and then we'll do the declaration and then we'll do the previous minute. Okay, Arlene?
Okay, yep. Can I just take this opportunity to remind everybody that the meeting is being recorded and will be placed on the websites of the Health and Social Care Partnership and Dundee City Council for public viewing. And I'll now take a roll call for the minute. Pat Kilpatrick.
Here.
Councillor Lynn.
Yeah, I'm here.
Councillor Toland. Councillor McHugh.
I'm here.
Donald McPherson.
Yep, I'm here, Arlene.
Sam Riddle.
Present.
Diane McCulloch.
Present, Arlene. Apologies, having a bit of problems with IT.
Okay, thank you. Vicky Irons.
Yeah, I'm present, Arlene.
Dave Berry.
Present, Arlene.
David Wilson. Susie Flower.
I'm present, Arlene.
James Cotton. I've had apologies from Raymond Marshall. Jim McFarlane.
Morning, Arlene. I'm here.
I've also had apologies from Christina Cooper and Liz Goss. Martin Sloan.
Present.
Emma Fletcher. David Shaw.
Present.
Thanks. That concludes the roll call. Item 1 is apologies for absence, which have already been noted. Item 2 is declaration of interest. Are there any declarations? No. Okay. Item 3 is the minutes of previous meetings, which were held on the 23rd of August and the 25th of October, and they're submitted for approval.
Okay, thank you for that, Arlene. First, the minutes of the 23rd of August. I just need somebody to propose and somebody to second those, unless there are any comments or corrections. No, so I need a proposer. I've got Donald.
Yeah, I'll propose them. I'm happy to see that the comments I made before have been taken on board. Yeah, thank you.
Yeah, thank you, and thank you for doing that, Donald. And Ken, okay?
Yeah, I'm happy to second.
Thank you. Okay, so moving on to the minute of the 25th of October. Again, if there's any comments, any changes you want made, then let me know. Is that right? We get 3 sets of minutes, Ali?
No, there's 2 of the IJB, and then there's a set for the Performance and Audit Committee.
Yeah, right, okay. That's what I was looking at. I was thinking, where am I getting all these minutes for? So I need somebody to propose and somebody to second the October minute. I get somebody to propose for the October minute, board member.
Yes, Arlene. Yeah. Yes, Pat.
Ken and Sam. That's great. Thank you. And then we have the Performance and Audit Committee minute. That's just for noting, I take it. Oh, that's into the next. That's into the next agenda item. It's the action tracker we need to go through now. We had a discussion about this the other day. Are there any points that anybody wishes to bring up on the action tracker? It was reviewed recently, and I think it has been updated, hasn't it? Yeah, Vicky's nodding. So we had some comments at the pre-agenda meeting, and it's been updated. So are there any, I mean, there are some things like the mental health and disability improvement plan, which are really just ongoing, aren't they? There's, you know, they're going to be on the action tracker for some time, Vicky, aren't they?
Yes, that's right. We'll bring back updates as required.
Sorry, I should have said one thing when we were taking the roll call. I hope this is okay, but Beth Hamilton asked, as the incoming chair, if she could be an observer on this meeting. So Beth is actually an observer on the meeting, just so that everybody is aware of that. Good morning, Beth. I should have acknowledged you at the beginning of the meeting. My apologies. Okay, so to go back to the action tracker, is there any questions? Have anybody got any points they want to raise around any of this? It's in progress, most of it. There are things that are just going to be ongoing. There will be things that come off the tracker and things that come on. I'm happy with it. I assume everyone else is happy with it.
Yeah.
Okay, it's duly noted. Thank you for that.
Sorry, I've
Dorothy
had my
has her hand
hand up. I've had my
Oh,
hand
sorry.
up for a wee
Oh, I'm
while.
sorry, I didn't see you there. Hold on, Maureen. Right, who's all got their hand up? So I've got Maureen. Can you come on screen, Maureen? Dorothy, sorry. Can you come on screen, Dorothy, so we can see you?
I'm on screen.
Right, I can't see you. I've got too many people, but yes, my apologies. Sorry, I didn't see you had a.
I actually had my hand up when it was the minute of the last meeting, because I had a couple of things I wanted to raise on that, but I also have a comment on the action tracker as well.
Okay, well, start with the minute of the last meeting. My apologies. I can only see so many people on the screen at any one time, Dorothy. It's difficult.
That's okay. So on page 2 of the minute of the previous meeting, item 3A, it was suggested, the last sentence, it was suggested that consideration be given to arranging a discussion in relation to governance issues. Is there any update on that? My second question is quite similar. It relates to myself, Councillor Lynn and Pat Kilpatrick would have a general discussion about integrated impact assessments. Now, I don't see anything happening with either of these. Can we have an update if there is one?
Well, that's actually my fault. I should have organised a discussion about that, so my apologies for that. And we'll have to put that in the carry forward, Dorothy, if that's okay.
Yeah. In relation to a session on governance issues on the action tracker, item 4, I think, speaks about a programme of IJB development sessions on strategic planning. Again, is there any update on this? I'm really quite interested in being developed.
Okay. I'll hand that over to Dave. He's got his hand up. Dave?
Yeah, thanks, Pat. Thanks, Dorothy. Yeah, I think there's been a few discussions we've had over the kind of past few months, which kind of points to the need for us to have a sort of kind of development session on governance. So there's kind of a number of things that we've kind of flagged up and over the course of the last few meetings. So we did say we would have one. We're hoping to get one before the end of this calendar year, but the adult support and protection inspection kind of came over that period, so we had to kind of defer that. So we're looking to get dates in over the first quarter of next calendar year, so into 2024, to kind of hold a session on governance, and we'll also kind of have one on strategic planning as well. And obviously we've got the budget development sessions too, so it's going to be a bit busy time developing over that period.
Okay, thanks, Dave. One of the other things that I think we spoke about earlier was some kind of a session on analysing data. It is somewhere, I couldn't find it in the notes, but it is somewhere. So if that's something that could go into the mix as well.
We could put that as part of the strategic planning kind of session, because it all kind of ties in with that.
It was just to say, I think that one's captured in the action tracker to organise that session.
All right, okay. Thank you.
I think it's a good point that you make, Dorothy, about the development of the IJB members going forward. I think that's important, and I think the governance issues are changing all the time in health and social care partnerships, so it's important that we kind of reflect on that from time to time.
Yes, I've been on this group for quite a while now, and I still struggle with a number of things. So yeah, I think that would be really useful.
Yeah, and the data analysis thing is good as well, because there is a lot of data out there, and it's sometimes difficult to see the wood for the trees when you're looking at information. So it's a good point. So thank you for bringing that up. Okay, and my apologies that I didn't see your hand. Okay, so that takes us on, if we note these things to go forward in the action tracker, I'm happy to do that, and I will pick up with Ken, and we'll get a date in the new year for the impact assessment meeting. So moving on to agenda item 4, which is the previous minute of the Performance and Audit Committee of the 22nd of November, which Ken chairs, and Ken's chairs assurance report and the terms of reference. So I'll hand over to Ken if there's anything specific you want to draw our attention to, Ken.
Not other than what's in the report. It was a relatively short meeting as far as the Performance and Audit Committee meetings go. So nothing to add to what's there on the report.
Okay, thanks, Ken. And has anybody got any comments on or any questions for Ken on what's in his report and his chair's assurance report? And I see you've got revised terms of reference. Is that just a regular sort of annual update, or were there specific things, Ken?
Well, that's just the next agenda item. That's for us to agree.
Sure. But
Yeah.
was there anything you wanted to draw? Because we've all read the papers. Is there anything you wanted to draw attention to? No.
What, on the assurance report?
Yeah.
No. As I said, it's all there.
Short report.
It was
Yeah.
a relatively
Okay.
short report. Meeting.
Okay. Okay. So we note the minutes of the Performance and Audit Committee. We note the chair's assurance report. And this is the committee presenting revised terms of reference to the IJB for sign off, presumably. So everybody's read all of this and the section on risk assessment. Is there any questions anybody wants to raise? Dave's got his hand up.
Yeah, thanks, Pat. Just a couple of things on this one. So this is actually, it's the IJB that decides on the terms of reference for the Performance and Audit Committee. So it's not the PAC kind of presenting its terms of reference back. So just to kind of be clear on that side of things. It's in the report anyway, but the terms of reference haven't been updated since 2016 when the IJB established the Performance and Audit Committee. Over that period, the PAC has evolved in terms of what it kind of considers, what it reports on. That's kind of been driven by a number of different factors, including internal and external audit recommendations, but also kind of requirements that the PAC have kind of put in themselves in terms of their own governance within that. So the revised, so that the kind of terms of reference that we've got in the report today largely reflect an updated position in terms of the evolving nature of the Performance and Audit Committee. Also compliant, kind of brings it up with compliance with sort of kind of best practice guidance and also external audit recommendations, because the external auditors have kind of made recommendations around our terms of reference as well. And also some kind of minor kind of changes around updated terminology. So things like hosted services are kind of replaced by lead partner agencies and things like that as well. So it brings us up to date. It brings us in line with best practice. So looking for the IJB to approve that today.
It doesn't say very much, Dave, about the performance information that goes to the PAC. Does it?
So I suppose I suppose it's for the PAC we do talk about performance somewhere. You can't see it because it's in front of them.
It's just that over the last year, I have raised the issue of not just the standard performance data that we produce that is supported to Scottish Government, but should there be other areas of performance looked at from time to time, whether that's on a regular, whether you have data that you bring regularly because you think over the next year that's going to be important, or whether you say, well, we're going to do a deep dive into, I don't know, social care our performance in providing social care, or our performance in delayed discharges, which in brackets is excellent at the moment, close brackets, or our performance in any other area. It doesn't really say the committee has the ability or the power, I suppose, to undertake to request additional performance information, which is not just the information that's presented to Scottish Government?
I think in terms of when you look at the duties, so I mean it's a coverall. I mean, because it's the terms of reference, we don't want to be too specific in terms of the information that's required. So there's a question. So under the duties 8.1, for the very first kind of section there, but first bullet point, the preparation and implementation of the strategy for performance review and monitoring the performance of the partnership towards achieving its policy objectives and priorities in relation to all the functions of the IJB. So that's the kind of catch-all there. It's up to the Performance and Audit Committee to then decide how it wants to kind of what information it wants to do that. So it doesn't kind of specify. It's only the kind of the national benchmarking information. Indeed, in terms of the way the park has evolved over the years, and we do kind of cover a whole range of other sort of kind of performance reviews that don't just kind of tick the box of this is what nationally we're required to do. So we'll have kind of drug and alcohol indicators. We've got mental health specific kind of indicators as well now. So in terms of the terms of reference, we wouldn't want to be too specific on that to say this is what we want.
But you think it's covered in the wording? Yeah.
I think that first bullet point is the one that kind of covers as a catch-all for the performance review.
That's what I wanted to know, whether people felt it was covered in the wording. Okay, does everybody agree with that? If you're happy with that, yeah. Okay, I've got a couple of other people. Thank you for answering my question, Dave. I've got Dorothy and Donald. Dorothy?
This is a linked question that I've got. I think 8.2 as well, Dave, which is the bit I've got a question on, says that the PAC should review progress against the outcomes set out in the strategic commissioning plan. But what I want to ask is, do the reports that come to PAC relate directly to the strategic commissioning plan? Do they?
Yes. So in terms of the information that we present, it all kind of ties in with what we're trying to achieve and what we're setting out in terms of the IJB. So those indicators that are kind of reported back. So kind of going back to even things that I just said around developing mental health indicators, the substance use indicators, etc. They should all be relevant towards the delivery of the IJB, what we've kind of set out within the strategic plan itself.
Okay, I'm content with that then. If the reports that come to PAC relate to our commissioning plan, because I think that's what we should be looking at.
Sorry, Dorothy, it's something we can. So in terms of that kind of earlier request around the a session on the sort of performance information, I think we can maybe kind of make that clearer for members, and when we have that session.
Yeah, thank you.
Okay, Dorothy. Yeah, Donald.
Thanks, Pat. It was just on the comments from the external auditors in the covering paper, where it talks about doing an annual evaluation and then also having a training programme in place for PAC members. And I mean, it's all very well sticking these things in terms of reference, but it probably needs an action, well, either from the board or possibly PAC, but I suggest perhaps from the board to management to put these measures in place so that we don't just lose sight of it along the 101 other things that need to be done. So I think I've just asked that we capture that as an action.
Can we maybe ask the chair of PAC, Ken Lynn, and his PAC members maybe to come up with a proposed programme? Would that be something that you could take away, Ken?
I don't see why not. I just worry a wee bit that, well, as Dave outlined earlier, with the budget development sessions we're having, that our diary might become a bit too crowded. But certainly once the budget has been, we've had budget development sessions and the budget's been signed off, I think that's something we should be looking at as in the next financial year, the early part of the next financial year. Can I just add something while I'm on? There's some unfortunate wording, I think, in
which bit, Ken?
10.1 review. the terms of reference will be reviewed when the chair passes. I think I should say rotates, to be honest, because
Yeah,
I mean
okay.
certainly the chair. If the chair passes, like the chair will
You
change.
can do what
but
you
I
like
think
at that point.
if we could word it a wee bit differently, because
Yeah.
yeah.
Okay.
I mean, I know everyone's laughing, but I think the word is a wee bit awkward. We could just say rotates rather than passes.
Okay. Okay, I'll leave that with you,
Yeah.
Dave, to change the wording on that. Or who's ever in charge of this paper. Yeah, it's come from the finance department. Okay.
Yeah, I'll
So-
change that.
Thank you. Yes, we don't want the chair passing. Thank you very
Yeah,
much.
see that this issue, I guess, it keeps coming up, doesn't it, about training? Because Dorothy's been talking about it before when we were looking at the action points, and now it's coming up again on this item. So
We haven't really had a programme, Ken.
No, I know. It's clearly something that keeps coming up that we need to be looking at
We need to
post
probably
budget.
publish a programme for the year ahead
Yes.
of IJB board member training, so that people
Yes.
feel they've been equipped by the IJB to do the job that they've been appointed to do.
Yes.
I'm going to
Okay.
leave that with Dave to come up with that for the next meeting, for the February meeting. Is that okay?
Yeah, that's fine, Chair. Thanks.
We'll put that on as an agenda item, and it just needs to be an outline training programme of what you think we need to provide. And it might be that in the interim period you want to ask out to IJB members and ask them what areas of training they feel would be most relevant. Because people have got their own views of what they feel they're strong in and what they feel they're less strong in. We'll leave that with you, Dave. Thank you.
Yeah, that's fine, Pat. Thanks.
Okay, so in terms of the terms of reference, and I note Donald's point, which is important, that these actions that have been flagged up by the auditors are going to be taken forward, and that's the formal training, but also the annual evaluation, and we're noting that it doesn't cover counter fraud and corruption. So where does counter fraud and corruption get covered then, Dave?
So that's something new that we'll kind of put in terms of coverage for the Performance and Audit Committee. Now, in terms of the IJB itself, it's actually kind of more the policies that are in place for the partner bodies that will kind of then feed into that. So we'll kind of work with partner bodies around kind of getting some assurances around that side of things.
So partner bodies, will they report back into PAC, or how
We'll
do we get our
see.
assurance on the counter fraud stuff?
So similarly to how we kind of get assurances on some other aspects through the audit process, and we'll kind of actually kind of seek assurances from both the partner bodies in terms of the arrangements they have in place for kind of fraud and corruption to make sure that they're robust.
Okay. Okay. Right. Are we happy with that? Is everybody happy with that? Yeah. Okay. And we've talked about the training programme, and they're suggesting there's an annual evaluation to assess whether the committee's achieving its objectives in line with the terms of reference. I think we need to leave that with the chair of the PAC to undertake that with whoever and what other board members are on that committee, and do an annual review. It doesn't have to be a big process, but I think we'll have to have it, and it has to be recorded. I think that PAC have undertaken that. You got your hand up again, Dave?
Yeah, just to come in on that. So for the first time this year, we actually, the PAC took an annual report to the IJB and kind of presented like an overview of the activities. So I think we can develop that. So in terms of that particular aspect, we can develop that a little bit further to kind of then that becomes almost the kind of the evaluation report. So we can work on that over the year.
Yeah. Okay, that's great. Right, I hope you've got all that, Arlene. So we're happy to accept the terms of reference then? Yes? Okay, as they are. Okay, that concludes item agenda 4. I'm now moving on to item 5, which is the delivery of the primary care mental health and wellbeing framework, which is the Chief Officer report. Quite a significant report with paper behind it, and a lot of interesting stuff going on in mental health. So I'm assuming you've all read the paper. A number of other faces have appeared on the screen there. So we've got Emma and I don't know if anybody has specific things they want to say about this paper, either about the covering paper or the mental health progress report in itself, or ask any questions. I'm going to open it up. So I've got Dorothy.
Thank you. I've got a question on the report, the progress report at 8.1. It gives an overview of PALMS, and it says patients can book themselves into a PALMS appointment, which will typically be a single 30-minute appointment. I just wondered how this is promoted. You know, how do people know that this is there, and how to access this service?
Okay, Emma's got her hand up. I think she's got the answer for you, Dorothy. Emma, we'll bring you in here.
Hi there. Yeah, thank you very much for allowing us to present this paper and framework to you today. So I'm Emma Lamont, so I'm the programme manager for this piece of work. So that's a really very good point, so thanks for asking. How is it promoted? So we have the patient assessment and liaison mental health team within the GP practices every week. So they have allocated sessions within the GP practices, and it's promoted via the GP practice. That's probably the best source of knowledge and information about its availability. There's a number of distinct services within the multidisciplinary team, so as well as PALMS, which is the Patient Assessment and Liaison Mental Health Service, which is staffed by mental health nurses. As well as that, we've got our primary care link workers, we've got the community listening service, we've got distress brief intervention, and we've got welfare rights advisors as well within the GP practices. So they all know about each other's work very well, as do the GP. So that whole cohort and team will be linking and connecting people very much so to each other. However, we are in the process of putting together our development plan and a delivery plan for the next 3 years. And I think raising awareness is one of the key features where we will be looking to do that. So any feedback or information that you would like to give regarding that, we are at the moment just building our stakeholder engagement with other practitioners, professionals, the public, and other community groups, just to try and reach as far as we can to the public in order to make sure that people know about it, because it is a very good service and team that we're growing and developing, and we're keen that as everyone in Dundee knows about it. I'm happy to answer any other questions about that.
Emma, thank you for that. I mean, really, yes, there are really good services available here, and I'm just, wanting to make sure that people actually know they exist and how to access them. So that's good. Thank you.
Okay, thank you, Dorothy. Shona, did you want to add to that? On you go.
Yeah, it's Emma's given a really helpful response. It does sit in the context of other work though, so there's specific things around the mental health and wellbeing services, but we've spoken before at this board around our lack of communication around some of the developments within primary care. So now that we've filled a couple of vacant posts that I've had in my team for a little while, we're looking at some sort of much more active promotion around the things that sit linked to practices, and also looking at some training for admin and reception staff around care navigation. So those things were in the primary care improvement plan that we presented, I think, probably in August. So there's some mental health specific things, and absolutely the work that Emma's doing, raising awareness of these and bringing teams together, looking at who's best placed is absolutely vital. But there's the wider context. So we're looking at the moment around a project with putting TV screens into reception areas, updating practice websites, the practice admin training and things. So there's a number of things that will sit alongside the specific mental health stuff.
Thanks, Shona. I think I've got a question from Donald then. I've got a few questions. I'll bring you in, Donald.
Sorry, I think I was at the back of the queue, to be fair.
Well, I don't see. If you've got your hand up, can you come on screen? Ken's got his hand up.
I think we're all on screen.
Not on my screen.
I think it was Sam first, then Ken, then myself.
There should be
Jim.
a number next to the hand. Which shows the order, no?
Yeah. I don't see that. I've not got it on the iPad, but anyway, my apologies. Just shout if I've missed you out somewhere. So I'll take Ken then. Okay, Ken.
Okay, apologies to Sam, but
No.
yeah, just on, but going back to Dorothy's point about promotion, I notice in the community listening service, for example, at 8.1, I've lost my place here. Where were we? Yeah, sorry. Hold on a second. The community listening service, it gives statistics for the number of people who attend, and also sorry, I'm just still trying to find, yeah, and also the gender split, which is around 70% women and 30% men. I'm wondering if we can look at ways of really trying to get men to access this service, given that the suicide rate, for example, for men, I think it's a UK-wide figure, but Scotland probably similar, is 4 times greater than women, which indicates that men aren't coming forward to get the help that they need. So I wonder if we could come up with some innovative ways of getting men to participate more in activities like the community listening service. And in relation to PAMS, an awful lot of referrals there. There's no gender split given. I was just wondering if anyone's got any idea what the gender split is there. That's at 8.1.
I don't know if Emma or Shona are going to take that question. Emma,
I'm happy to answer.
Yeah,
I'm happy to answer
that.
Yeah, definitely. So yes, absolutely, really good points around the gender split within the community listening service. And I think going forward, we'll be looking at how we could be more reaching out into areas where potentially we know that men are, to try and promote the services. And that's a really important service. And the service is actually run by volunteers, trained volunteers, using a NES programme, NHS Education for Scotland programme. So again, how can we increase the number of men that we have volunteering in the listening service to make it more accessible for men to open up with other men as well? So that's a really good point. So I've taken a note of that. And I think they'll be glad to hear back at the community listening service. I think in terms of PAMS, it's around the same split, where it's more so women coming forward for support. And I think that's it's a national and age-old problem, isn't it? And I think probably a good point for us as we're looking towards our delivery plan, looking at the protected characteristic areas, so not just around gender, but other groups of people that we know are at high risk of poor mental health, but don't come forward and ask for help. So again, yeah, we will be looking into that. So thank you very much for those points, because having these things highlighted here certainly helps shape our thinking.
Thanks very much.
I think, Emma, I was on the Perth and Kinross IJB for a while, a couple of years, and the way that they did, the way that they approached the gender split issue was by commissioning, I think, and Beth will know more about this, she's on Perth and Kinross now, but I think they commissioned Andy's Man's Club. Was it Andy's Man's Club? I'm not sure if they commissioned them or they just supported them, but they had success in attracting men to come and seek help that we hadn't previously had, just because of the way that it was run and the kind of, it had a different feel to it and a different approach. And we did invite them into the P&K IJB and asked them to give a presentation on the work that they do with men. And some of them came along and they told their stories. And it was really very, some of them had attempted suicide and, had all sorts of bereavement, divorce, their businesses collapsed, and they didn't know, and they'd been in conventional psychiatry treatment and been on antidepressants, and none of it worked. And the only thing that worked for them was this Andy's Man's Club. Beth, are you online? Could you comment on how you managed to do that in P&K?
Yeah, that has been a focus, bringing in men's groups. But I remember from a previous time that the suicide strategies very much had an emphasis on engaging with the male population. And I know Angus, for example, with the football club, do a lot of work there, which is hugely successful in bringing people in. Peter Davidson who's a board member and up there, he talks about that. So I think with the big football community and the 2 football teams, there's a huge potential there of working with them to try and there was some work being done with that around the suicide strategies in the past. So I think there's potential, and I know there's a very vibrant men's shed in Dundee. So I think there are opportunities. It's just focusing in on them.
Thanks, Beth. I think that's helpful. Shona, did you want to come in?
Yeah, I mean, these are really, really important points. I guess what this paper does is reflect the core things that are directly linked and work from general practice. It doesn't reflect the huge amount of other activity that supports mental health and well-being. So there is an Andy's Man's Club, as Beth said, there's a men's shed. There's quite a lot of specific third sector activity in particular that are focused on men. So that's just not reflected in this, but equally it's a really key and huge underpinning support for people, including men.
Thanks. Thanks for that, Shona. I've got Donald, I think. Yes, I've now got a little list of everybody with a hand up. I've got Sam, and then I've got Jim, and then I've got Donald. Sam?
Okay, thanks, Pat. And thanks, Emma. That was a very good paper. A couple of points. On page 31, they talk about distress brief interventions. That's something I'd never heard of, and just what the impact of those are and how that works would be useful. And on page 47, they talk about access to appropriate IT systems will support PAMS. This has been a long-standing issue. I wonder what progress can be made in making sure that the IT systems are brought up to date to allow that to happen, because it's certainly all the time I was in Dundee, it was always talked about. Yeah. So those are my 2 points.
Thanks, Sam. Emma, is it Emma or Shona? Is it Emma that you're going to answer this, Emma?
I can talk about DBI if you want to talk about IT systems, Shona. Yeah.
Okay.
That's a good deal. So yeah, absolutely. DBI is distress brief intervention. This is a national programme that's been implemented nationally, and each local area is tasked with implementing it locally. So in Dundee, our DBI service is hosted by Penumbra, and we have a number of areas of focus. So one of the areas of focus for distress brief intervention is via primary care, another is via the police, another is via the Scottish Ambulance Service. So what distress brief intervention is that it enables practitioners working within these fields to be able to refer into a service that offers distress brief intervention. It's a peer-led service, and it offers people support within 24 hours. So if someone presents, in the ideal scenario, as we're working towards at the moment, because it's being phased in to all of the GP surgeries across Dundee, but it's not in them all yet. It's a phased approach. So a number of them, if you presented at your GP practice in distress, mental health distress, where there was concern, then they would be able to refer into DBI. DBI practitioner will make contact within 24 hours, and then they will support that person for up to 14 days in any way that they really need. And that could be done on a daily basis, or it could be done, you know, a couple of check-ins, or it could be connecting them into other services. What's worth recognising about the multidisciplinary team and services we're developing in Dundee is that we fully understand that we're sort of a small service potentially, but there's a huge range of third sector organisations that we can connect into. So what a lot of these services that we're developing do, although they offer immediate interventions and support and compassion and assessment, they also have a host of other services that they can connect and support people and navigate people to. So for example, for men, we know we've got a directory where we would know that could connect. I was speaking to one of the PAMS nurses practitioners the other day, and he was telling me, he says, I've never met someone that I haven't felt I've been able to help. And that's really good feedback, that there's something they can find on that day that could tailor for someone. And they also, although they see people as a one-off, they also see people say, come back to us, in that way that GPs build relationships. They are also looking to. And I know that DBI are looking at that same open door, no wrong door. Come back to us if you need us again. And I think that message is really important.
That's very helpful, Emma. Thank you.
Okay.
What you don't really say in the paper, I don't think, Emma, you're kind of hiding your light under a bushel a wee bit, is that Hope Point is the 24/7, 365 days a year service. And
Yes.
I was at a meeting with Michael Matheson and Shona, the Minister for Mental Health and Wellbeing. And what we did say was that what came out in that meeting was that was a unique service in Scotland. There was no other IJB providing somewhere that 365 days of the year, Christmas, everything, 2 o'clock in the morning, you could walk in off the street, and if you were in distress, and I think this Health and Social Care Partnership has got to be recognised for that work and that very innovative and very committed decision to fund that through Penumbra, and to commission Penumbra. And I think all of you and your teams have to be congratulated for that, because not one health board in Scotland is providing that level of DBI service to their population. And I think it's really unique. And I was really proud to be able to stand up at that meeting and say that. So I just want that recorded. I think that's a really important service in Dundee. So thank you to everyone involved in that. I had a couple of questions, but I'm going to let.
Can I answer Sam's question about the IT, if that's okay?
I was going to ask you to do that, yeah.
Yeah, sorry. And the Hope Point's a really important point. And Arlene Mitchell gives her apologies. She would have been here this morning, but actually she's at Hope Point, I think, with Marie Todd today, because a lot of the work that Emma's been taken forward has really been founded on both mental health work, and particularly Hope Point comes from Arlene working on that for a long period of time. The IT is slightly complicated, Sam. I know you'll understand more. Essentially, the PAMS team are based in practice and have access to the IT systems in practice, and currently, because of that, they can refer to other bits of the system. What we're trying to do is to move them to be more flexible, so if there's sickness or holidays, that they can cover other practices where they've got capacity, and IT access then becomes slightly more difficult, and it's the referral part of the system that becomes more difficult. But they're looking at whether the GPs then directly would have to do the referral. It's to do with the way it's set up nationally, so it's limited in terms of what we can change, but we think we're nearly there in terms of being able to resolve that. There's maybe a small implication for practices, but it will give much more flexibility in terms of cross cover, which will be really helpful, because the GPs become really frustrated if they've got a really good service that's there most of the time, and then somebody goes on holiday for 2 weeks and there's absolutely no cover. So it's how do we try to get our IT systems to develop that? So we're nearly there, we think.
Thanks, Shona.
Thanks, Shona. Yeah, and it's all good work, so moving on. Yeah, okay. So if you're happy with that response, Sam, I'm going to move on to Jim. I saw him on the screen a wee minute ago. Jim?
Yeah, still here. Thanks, Pat. It's really around the question around the points that are in 4.2.9. Outlining obviously the existing kind of great work that's done by the welfare rights team and Brooksbank, and they talk about probably developing that work further. But given the kind of budgetary kind of restraints and the expected, nobody's got a crystal ball, but I'm not expecting a budget that will be increased for those type of services in the country. How confident can we be that we're able to resource that kind of ever-growing need for this type of resource in those type of locations when there's already, particularly organisations like Brooksbank and others are already flagging up how difficult it is for them to deliver the services they already do.
Who's going to answer that? Is that you, Shona?
Yeah, it's something that we're really aware of. There's been Scottish Government funding to the welfare rights team to expand into a number of practices, but absolutely, Jim, there's even more work that they could do. We've been having some discussion about if you had further welfare rights staff in practices. They've got a lot of the sort of disability support forms that people have to complete are not particularly well completed by GPs. If you've got welfare rights team supporting that in practice and access to direct clinical information, that's really helpful. So the GP model is really useful for welfare rights as well as for the practice and the individual then that's receiving the support. So it is a challenge for us. I don't think we can give assurance that we can necessarily sustain the level of support in practice or expand that to practices where we've got a gap, and we do need to think about that.
Okay. It's maybe not the answer that you're looking for, Jim, but I think in the current financial climate, when obviously try our best to get as much money into the system as we can. And I think we've been reasonably successful in doing that. So, I think our teams will continue to try and put forward proposals and recommendations. But we can keep you up to speed, Jim, as we go along. Okay, so finally, I'm going to bring in Mr. McPherson.
Thanks.
He's been
Thank
waiting
you.
Patiently.
Thank you, Pat. I was slow putting my hand up, so fair's fair. No, I mean, and thanks to the Emma and the team for producing the paper. It's really thorough, well thought through, and it's good to read. I think the couple of comments. I mean, as I was reading it and noting that one of the recommendations is that the chief officer will come back in 12 months to report on progress against delivery, the question I was asking myself is, well, how will we be able to assess and judge the success or otherwise? I would like to have seen, measures of success in terms of, what will be the outcomes for the people of Dundee, and I can't find that. And I think without those sorts of measures, it's going to be quite difficult to look back in 12 months' time and say, well, yes, we did succeed or we didn't. So that's point one. And to be fair, it's a comment that I've made around a lot of papers. Another one specifically around, and I was really pleased to see social prescribing as part of the mix of measures that we can put in place. And it's one of the things, and Pat will remember, I think we've talked about it within NHS Tayside, and I think we all instinctively feel that social prescribing has to be the right route for a lot of people. But at the moment, it's quite difficult to make the financial business case for it, and to justify putting more resources in that direction. It's helpful if you're able to say, well, by emphasising social prescribing, then we're able to save this in other parts of our activity. And certainly I think my recollection was we weren't able to put our finger on that. And I wonder whether, as part of the outcomes and measures of success, we can find a way of capturing that. And my final point was just around, again, there's lots of references to the third sector, and it's something that's come up in the past about the need to make use of the services that the third sector can provide. I mean, the question's a simple one. How do we know that we've got the balance right now, and that we're making the best possible use of the third sector and supporting them to support us? So these were my questions. Thanks.
Okay, thanks, Donald. And some good points in there. I'm going to bring Shona in to answer that, if I may, Shona.
Yeah, Donald, your first point about outcomes and success, Pat said exactly the same thing at the pre-agenda, and we did try to put a little bit of wording in. It's kind of, I think it's because it's a framework rather than a strategy. It's a point in time, and part of the work that Emma's planning to undertake over the coming sort of weeks and months is how do we measure this and success. So I think there'll be a specific subgroup that's detailed that will take that forward, because it's absolutely key. I mean, obviously we've got performance indicators that have been agreed for wider mental health and wellbeing work, and we're tapping in both locally and at a Tayside level to that. So there are things that we can build on, but it is an area that we need to develop. So we recognise they're not there at the moment, and they do need to be, and it is a gap. So I think it's a timing thing rather than a sort of overt omission, if that makes sense.
Yeah, I mean, it does make sense, but I suppose my plea would be that we see that the output of that further thinking, not in 12 months' time, but I don't know, within the next quarter, so that we know what we're aiming for.
Yep.
Do you think maybe, sorry, I could interrupt you a minute, Shona, do you think maybe this is such a good paper, right? I'm really over the moon with the paper, and when I read all the work that's been done, and I wonder if we should maybe bring some measurement issues back, not necessarily to the next IJB, but at maybe 6 months down the line when you've had a chance to reflect. So maybe not maybe not the February meeting, but the one after that, March, April meeting, to say these would be some, high level indicators, because things like the take up of the service are important, but also, there are some proxy measures in there that you could use as well, couldn't you? So it's not easy to measure mental health, access to mental health services is probably one of the most difficult areas. Because sometimes if more people are using the service, are they the right people? Are they the people that actually needed that service, or are they the worried well, but they're not actually really unwell? Or, do you know what I mean? It's a bit of a nightmare. It's not like hips and knees and, hernias and all that. We can measure all that quite easily, but this is really difficult. So I wonder if it maybe give, and I don't know, Shona, has there been lots of research done into, because in England they've got a lot of indicators and they report on their indicators, and I don't know if there's been a lot of research with the Jamie Sinclair team at Scottish Government as to how do they know when they're putting in money to services that money is actually creating a beneficial effect on the well-being of a community like Dundee? Just interested, Shona.
The national picture is quite interesting, because when they sent out the original documentation around developing sort of local capacity and drivers for primary care, mental health and wellbeing specifically, they had an initial set of indicators that they'd agreed and they withdrew them. They didn't come forward. The wider mental health strategy then came out that isn't probably detailed enough for what we're looking at. There was actually an email came in yesterday a little bit linked to this, but again, it doesn't really give us that. So I think it's quite a significant piece of work. Equally around the social prescribing impact on system, I think, Donald, what you're describing is sort of avoiding appointments in other bits of the system, GP work, that kind of thing. That's quite complex to do. I'm sure you're not going to be surprised that I will say that. It's kind of almost getting into health economics, return on investment. It can be quite onerous to collect some of that data, but again, we'll try and pick that up through the subgroup that are looking at information and data.
Thanks, Shona.
And third sector absolutely would, agree. And I think Arlene is much more involved in terms of commissioning for third sector organisations, and we'll have a lot of knowledge around that. She's not here, but I mean, there's always a significant review. But again, I think developing the framework and how we best work together and what supports, Emma's going to be doing sort of some pathway mapping work, so that might highlight some gaps and some duplication that will lead to us being able to have a bit of a review of where we are with some of our support and infrastructure.
Yeah, I mean, I know I did notice there was reference to DVVA within the papers. I'm not sure if we have someone from DVVA, but I wonder what assurance they would give us if we have anyone at the moment on the IJB.
No, I don't think we do, Shona, do we? From DVVA.
Yeah, I think this is given their apologies, but they are really tapped in, and Emma links a lot, as does Arlene, with a number of people. So there's a significant infrastructure within DVVA that supports mental health and being, including engagement, feed in from the public. So there's a lot of linkages with DVVA around mental health and wellbeing.
Okay, thanks, Donald. Beth's got a hand up, and then I've got Emma, and then I've got Dorothy. Beth?
Sorry, I don't know if I'm allowed to talk, but it was just really on some of the...
Did we stop you? That's the question.
No, I was just going to say the first thing about the data, etc. I said I'm not too worried if they've not got a whole raft of data, but I think what we really need to be assured is the baseline of what they're going to collect is done now, so we've got the comparisons ready. But what I was more interested in, and I can talk to Donald about it till the cows come home, is about social prescribing and the values of social prescribing in business cases. Social prescribing has been around for a long time in mental health and wellbeing, and there are many business cases that you could pick up off the net. When I was working in Edinburgh, we had a lot of work around the financial economy and benefits of social prescribing. But I think what's even more important just now is if you look at our prescribing budget across everywhere, it's going through the roof, and the amount of people that are being put on antidepressants, etc. So I think if you start to look at it, there are plenty of templates out there, but social prescribing, I think, is really the way forward. So it was just to put that into the mix.
Okay, thanks, Beth. That's helpful. Okay, so then I've got Dorothy.
I think Emma was before me.
Oh, my
Pat.
apologies, Emma, you were before.
It's just to come in around the measures and the outcomes. So actually, when I opened my emails this morning, I was delighted to see that Scottish Government have published primary care, mental health and wellbeing outcomes and measures. It's just been published in the last week or two. So from a read of that, what they're looking at, and I think that's been the delay for ourselves. You know, do we create our own or do we wait? We knew they were coming, and so it's great to see this. So we'll probably be taking them and seeing how we will use them, and do we need to adapt them in any way. But from the first look, they're looking at measuring around, I think we talked about this before, protected characteristics, deprivation, poverty. So making sure that we are reaching the right people. There's no point in being very busy providing mental health and wellbeing support when actually you're not reaching all of the people that you need to, and those who need it most. So again, looking at that, and then for individual outcomes, looking at getting lived experience and service user feedback, and the number of people who are stating that their mental health and wellbeing is improving or improved, and that kind of thing. So I think we probably could bring you some measures in the next quarter or so, if that would be useful. I think we could have a subgroup and look at that.
Are these is this notice that's come out, this letter that's come out, are you in a position to share that, or is it in confidence until?
I think it's open access. I could share it.
Yeah, it would be,
I'll double check.
Be useful for the IJB to see what's been proposed, if that's an official. Saves us all going hunting for it, Emma, on the website. So thank you for doing that. If you would do that today, that'd be great. Okay, and then I've got Dorothy. Dorothy.
Thanks, Pat. Shauna's initial response to the question about measures suggested that it was because this is a framework and not a strategy. It seems to be a trend. I've noticed there's a trend now for frameworks rather than strategies. And is that perhaps a feature of frameworks, that they don't have systems for measuring and outcomes and things like that? If so, it concerned me. Why is it a framework and not a strategy?
Jonah?
I think it's a timing. So I think we felt that it was really key because of other sort of strategic drivers we have around primary care and mental health that are in place already, that we pulled that together for the context where they overlap and dovetail into primary care. And also, we absolutely recognise that we've not done the engagement and consultation that we would need to develop it as a strategy. So I think anything that we were bringing as a strategy would be have a much wider input, which we can do and will do. And Emma's tried to describe what she's planning to do around that. So we could have called it any number of things. It is a stock take, really, and trying to develop a plan in terms of how we move forward. And I think it does that really well. Whether it should be called a strategy or a framework or something else, I'm not sure.
I think the principle is just that we get the measurement in, you know, whether we call it a framework or a strategy or an outline or, you know, a plan or whatever. I think it's just really important, and I hope people agree with me that we get the measurement in there at an early stage, so that we know we're putting a considerable amount of effort and there's a considerable amount of money being invested, and we want to get to the people that need the service, don't we? We want to make sure that they're the right people that are accessing the service. So it's a very valid point, Dorothy. Okay, and you can see there's a very detailed integrated impact assessment here. I don't have to go through it, but it's detailed and explains how they think this will impact on the communities that it serves, against inequalities and socioeconomic deprivation and so forth. If everybody's happy with the framework as it stands, I think, are we being asked, Arlene, to, we're not being asked to give note it or give limited assurance or anything, we're just being asked to approve it. Is that right, Arlene? Where are you?
We're sorry, I'm here. Yep. We're being asked to note the local and national strategies, note the progress to date in delivering the framework note the progress review, but approve the recommendations set out on page 21 of the progress review.
Okay.
And then to instruct the Chief Officer to provide a further report.
Okay, so are we happy? Is everybody happy with the recommendations and what we're signing off today?
Pat,
Yes.
I have a question on the integrated impact assessment.
Yeah, on you go.
On page 4 of the integrated impact assessment, it tells us this impact assessment has further highlighted the absence of developments in primary care in Dundee for children and young people under the age of 16 and 18 years old for those still in school. And under equality, diversity and human rights impacts, that's the first one at the bottom of the page. It says there is no impact in terms of children and young people as this framework presently supports adults only. I would suggest that should be a negative impact for children and young people.
But it's not.
Maybe I'll keep this discussion for whatever discussion is arranged on integrated impact assessments and how they're scored.
No, I don't think you need. I don't think you need to keep it. I think this is a framework for adult services, so it wouldn't impact. It's not designed to impact on children. It's not designed to provide services for children, so it has no impact. Well, it has no perceived impact on children. Is that right, Shona? Because it's not geared up. It's not designed for children and young people.
Although it does highlight in the narrative that the absence of developments in primary care for children and young people.
Yeah.
You know, it actually says that.
It does.
Yep.
So I'll let Shona answer this.
Yeah, when the initial guidance came out from the Scottish Government, it was very much focused on adults. And then before we put in a submission, probably about 18 months ago, when we thought we were getting funding for this work, it highlighted that we should be thinking across the age spectrum, including children. What we've done is to reflect the work that is happening, but certainly if you speak to families and to clinicians working in primary care, there are gaps around children. So we are trying to, and when was linking across to CAMS and other teams around children. Emma with the Corner had submitted a bid around funding that wasn't successful recently, that was focused on children and that gap around the lower level support that CAMS wouldn't necessarily do. So there is things in there around children. The disparity, Dorothy, in the impact assessment, we had that debate as well as to what we should write, because we felt that the framework currently doesn't reflect enhancing care for children, but equally the things in the framework don't have a negative impact on children. So that's where sort of the contradiction comes in relation to the wording in the two different sections.
Okay, well, I think that is something for the discussion that we will be having later on impact assessments. Thank you.
Okay, thank you. Thank you for your response, Shona. That was very helpful. So we've been through the paper. Lots of questions have been raised. We've been through the impact assessment. Again, points have been raised here. I wonder around the children and young people, is that going to be another framework that's going to come to this committee at some point, Shona?
No, I don't think we see it as being separate. I think we see the framework as being an evolving document. So we will add to that as we become clearer as to what are the gaps and how do we potentially fill those. So I think this is a dynamic document and we'll just add to that. I don't think we were intending to do a separate paper around children. Emma's shaking her head. So
because there are long waits, obviously, for CAMS. So there's a big, there's a point where how do people that are on a waiting list, how are they managed and what support can they get whilst they wait for an appointment? And it's not just the difficulties of the first appointment, it's then getting the second appointment. And so I think there's probably a big issue out there for children and young people around access to services. And as you say, that kind of lower level who've maybe not had the referral accepted, because not all GP referrals to CAMS are accepted by the CAMS service. So there'll be people who are referred who are not going to be seen at all, and what happens to them. But I just see Diane's hand has gone up in the
yes.
side bar here. So am I going to
thanks, Pat. Hi, yeah, happy to come in, Pat. I guess the issue in terms of the work around CAMHS is very much part of the mental health and wellbeing strategy that's being managed through NHS Tayside, because it is a Tayside resource rather than a local Dundee resource, which we tap into. But I think the points that you make about where do GPs go if that isn't an option for them with CAMHS, if they're not meeting the criteria for CAMHS, is something that we can feed into that programme of work that exists already looking at CAMHS in terms of their pathways and the work that's there. So it doesn't sit within our direct responsibility in terms of response to children, but we work very closely with our colleagues in children and family services and also our colleagues in mental health services to make sure that if we need to consider those pathways, that we can tap in and feed into them where we can.
Yeah, it's more about the issue, as you say, of when you can't, your referral's not accepted, or people, that's not their first point of call if they haven't gone to the GP. But there are a lot of referrals which are not accepted, and it's what happens to these children and families in the meantime. I'm going to bring Siobhan in. I see you've got your hand up, Siobhan. Nice to see you. Good morning.
Yeah, sorry about that. My internet went down. I mean, this is more maybe for kind of young people, and it's maybe just worthwhile pointing out, and it would just be for students only. But, you know, coming from working at a disability service at the university, there is a mental health mentoring service that can often be used. I mean, strictly speaking, it's a kind of study skills based support, but it is often used as an interim form of support while students are waiting for referrals and so forth as well. And that would be universities across Scotland, actually. In addition to that, Dundee University does have a student crisis service as well that's run by mental health nursing. So if there's students, there's a kind of an extra layer, I suppose, of support that could be useful. Might be worthwhile pointing that out as well.
I think that's really helpful to understand that. It's all changed since the days I was a student at Dundee University, but
definitely.
Yeah, but I think it's more the worry, isn't it, of the kind of 12 and up, between eating disorders and self-harm and you know, a lot of these other problems like anxiety, depression, and so forth. And it's how we support young people through until that, you know, until adulthood, because we've got very good services now for adults. But if you're not an adult, the worry is that the services are not there in the same way. So I suggest that Emma's got her hand up again. Did you want to come back in, Emma? Is that an old hand?
It's not an old hand.
Oh, okay.
It's just to say very briefly.
You were old and you had old hands, but you know what I mean. A legacy hand, I should have called it.
Very briefly about children and young people. I think the discussion that's ensued around children and young people is the one that we've been having in the primary care mental health and wellbeing groups and steering groups that we've got. And certainly what we've got planned for January is a mapping event across all of the children and young people services in Dundee. And just because we hear a lot of conflicting information and different information, and it can be a little bit confusing. Is there enough resource? Is there not? What is the resource? Where the gaps are? So we're aiming to find out. And part of maybe what we can do is look at optimising and raising the awareness of all of the services that are available, so that people know that they're available and what they're for. There are developments within CAMHS as well, you know, to reach out and support families who don't meet their criteria. So again, we're working to link with them, and school nursing is also evolving and developing as well. So I think we need to get real clarity on what is the need, where are the gaps, and then what is the role for primary care within that, that we can work with that. But there's many options. It's just getting clarity. Again, as you say, investing money and resources, it needs to be going in the right place to the right people and the right needs. So it's underway. It's going into the delivery plans. So
because I know CAMHS have a very good website as well that they've developed to try and help people access services. So it's a really good point. The question is, committee, whether we want to bring this children and young people mental health issue back into this agenda, into this committee, and maybe in February or in April, to maybe hear what the outcome of your mapping work is. And what, it doesn't need to be a big paper, Emma. It just could be a paper saying, this is what the work's ongoing, this is what was discovered today, and to give some reassurance to the committee that, you know, where the gaps are and how we plan to address them. Just do committee members think that would be helpful if we brought it back maybe in April? Yeah. Okay. You okay with that, Diane?
Chair, I was actually wondering whether or not we take this back to the group that are working on that information and perhaps come back with a recommendation to the next meeting through the action tracker rather than making a decision just now, because we'd want to be confident that the group felt that they were able to bring that paper back and it wouldn't be requiring other people to do so. So perhaps if it goes down as an action for feedback at the next meeting.
Okay, I'm happy with that. Everybody happy with that? Okay, so we are approving that. Thank you very much to Emma and Shona, Diane and everyone else who's been involved in putting all this work together, putting it all down on paper. It is very impressive and I think we've done a really good job here. So thank you for that and thank you for coming along answering all our questions today. So moving on, you're very welcome. So moving on, Arlene, you just keep me right. I'm on item number 6 now, which is the Dundee General. Thank you, Arlene. The Dundee General Practice Strategy 2024 to 2029. I'm sure maybe, is David going to talk to that? David Shaw's online, aren't you, David? Good morning.
I'm here. I think we're going to do.
Oh, sorry.
Yeah. You go for it, Shona. Julia's paper, so I think she's leading off on it.
Right.
Yeah, she was going to do a short presentation.
Right, I'm not steal your thunder, Julia.
That's all right. I thought I would just do a quick recap of it, if that's helpful, and perhaps helpful, people have read it. It would be okay.
Okay.
Thank you.
Okay.
Can you see my screen?
Yeah.
Yeah, thank you. So we're bringing today to the Dundee General Practice Strategy. So that covers 5 years through 2024 to 2029. I don't know why I've put 2027 there, just to see if you were all awake, I think. So we've built that on a vision. So just to quickly repeat what it is, this is what we're trying to get to as our future state. So this is our aims. And I don't think anybody will have any argument with, trying to achieve high quality, patient-centered, sustainable general practice services delivered by highly skilled, motivated staff that improves health outcomes and reduces health inequalities for the people of Dundee. So a lot of ambition in there, as you'll agree. In trying to develop a programme of work that will achieve that vision, we wanted to try and do some things that would help us to do that over the next 5 years. And one of those was to be really clear on the scope of the services and on the scope of the work programme as well. So dentistry and optometry, eye care, that sits within NHS Tayside, so they won't be covered here. In this strategy, what is included is the general practice GPs and practice staff, and then these other services that support general practice. And I've listed those here, and some of them obviously you'll recognise from the PAMs that Emma was talking about just now. And then there's also the urgent care teams that support patients at home and the community treatment services, so not necessarily sitting in the practice, but other services that are supporting general practice and providing that specialist knowledge. And we also needed to stay grounded, and I did this when we were talking with the public, the citizen groups. We can't ignore all of the challenges that we have in general practice in terms of recruitment of GPs and nurses, the increasing patient numbers, deprivation. I mean, all of the things that you'll all be very familiar with, so I won't go over those. I won't labour the point. So in order to get us through to how do we develop a work programme, we came up with 6 areas of focus. And these are kind of like the sort of building blocks, really, of the strategy. And alongside, in the bottom right-hand corner there, you can see a little graph, because what we wanted to do was also consult with the public and ask them for their views. So I went to quite a few citizen groups across Dundee, and we also did a survey where we had low numbers. We had 61 survey returns, but that's what you're seeing there. And I don't think it'll be any surprise to anyone to see that access is the number one area of focus for people. So a description of all of those is in the document, and again, I won't labour the point on that. So then we developed some guiding principles. What will we have that will drive the behaviour and the attitudes that we need to be able to execute this strategy? And so we've set those out there. And again, the citizens were asked do they feel the right things to do? And everybody agreed they were the right things to do, and they were asked to prioritise them, and their priorities were around right care, right place, right person, and taking account of the patient's story and making service changes that are informed by data and evidence. And I think we had a little bit about that earlier as well, haven't we? And that was followed by 20-minute neighbourhoods. So, you know, this is around limiting the travel requirements, and that sits well with the green agenda, but also the need for travel and the cost of travel is kept low, which we know are barriers to healthcare for people in Dundee. And then we wanted to make this real, that it, you know, it made sense and we could take it forward and something would come out of this strategy. So we looked at what would be the key activities that we would like to do over the next 5 years. And again, we asked the citizens, and again, it was about improved access. And this is the area, and I think Dorothy picked up on this area. It's about, do the people of Dundee actually know what services are available? How will they know? And so one of our first pieces of work is to develop that area. And another big area for improvement is being able to access appointments. I think everybody will know about the 8 o'clock run for an appointment at a GP surgery. So we want to focus on that. I think that you can see that those that I talked to and that responded to the survey, they do understand the challenges that are in general practice. So you can see that they can see it's important to maintain a healthy workforce. And I think the other part of interest was quite a lot of discussion that I had with groups around prevention, and that came up third. And we saw that as an area to develop as well, keep people healthier for longer. From needing to access the service in the first place will help us to sustain general practice. And as we've read somewhere, the 20% of a person's health outcomes are directly attributable to their access to good quality healthcare. So there is something there about those wider actions that we need to do. So our recommendations to the board was that the strategy was approved, and that we would come back in a half year to give you some updates. And picking up about measuring and outcomes, what we would do with those is do them with each of the activities that we're doing. So in terms of the information, we'll do some baseline work, do the work, and then come back to you to show that the impact of that. So around like the TV screens that we're suggesting that we put into general practice. So each of these pieces of work, we would demonstrate where we were and what impact that had had. And I don't know if you've got any questions for Shona or David, and I would be happy to take those. And I return it to the chair. Thank you.
You're on mute, Patricia.
I'm on mute. So I was just thanking you for the paper there and for taking us through the PowerPoint. It was a really interesting paper to read. And not that all the papers aren't interesting, but this was particularly interesting because it highlights the challenges, and it highlights how we're going to, in some areas, how we're going to address them. So I'll bring in David if you want to say anything else, David.
Yeah, thanks very much. It's very instructive that one of the key issues for patients is access, and I think one of the key issues for general practice is sustainability, and it's quite a difficult square to circle. I'm not sure if committee members have observed the release of the latest Scottish general practitioner workforce statistics that came out yesterday, indicate that Tayside's lost another 3% whole-time equivalent GPs in the course of the last 12 months. So up to a point, we are running a little bit to stand still. That said, the vision of this strategy is really to wrap care around about communities and to see if we can get a degree of continuity, perhaps not necessarily always with your GP. And we do feel that there is an opportunity in various different realignments that have taken place within general practice to map services that practices provide directly more closely to the services that are provided by the partnership and by other bodies. That way, you can have a set team that is constant over a geography rather than perhaps losing a little bit of coherence by interacting with a variety of different teams. I think we've thought long and hard within the partnership as to how it is we can make sure that patients get the right care, which isn't always general practice led. And we have used the Primary Care Improvement Fund to make sure that people get useful services that are perhaps more appropriate to their requirements. And I think that's part of the reason why things haven't been worse. I think we are losing GPs, but we are gaining services, and we are, I guess, seeing how best we can work with the workforce that we have, whilst still trying to attract more folk in. It's one of the things that hasn't come through in the strategy. It's just the work that we've been trying to do in actively placing young doctors within Dundee. So we've used the Career Start programme to make sure that practices gain good support. We've encouraged practices to take on training roles. I think if you get them while they're young, then there's every chance you can get them to stick where you want them to go. We've had a very active programme of getting foundation doctors into practice. Do appreciate that not everyone is a fan of the phone first model that many practices have. I would say that with doctors and nurses in training, if you know what it is that they're coming in with, it does make it a lot easier to be able to direct people more assuredly to people who have the competence to be able to deal with that. So the fact that you go through the filter of a senior clinician before you end up in the best place does mean that you can sometimes try and retain some of the continuity, which I think people are looking for. You can be placed with the right person, and we can get more out of our entire team. So I wouldn't get away from the fact that we have a huge number of challenges in terms of maintaining sustainability. With sustainability comes access. So if we can build strong teams that go beyond GPs to include wider partnership teams, nurses, pharmacists, third sector, then I think we will arrive with those community-based, community-orientated practices that look after patients in the fuller sense. Big things that kill our patients, I guess, are to a large part the public health issues that are associated with deprivation. I think there's a table in there that shows our prevalence of various different diseases. What that table doesn't tell you is that our patients with strokes are maybe 10 years younger than the patients with strokes elsewhere in Tayside. So if we want to get in there and actually help to prevent early death and reduce the prevalence of early disease, then it's not just a GP response. It's a whole system response, and general practice fits into that. I will pause for any questions.
Thank you, David. And I mean, it made for quite sobering reading when you read table 13, figure 13 on disease prevalence. And if you read the burden of disease reports that are produced, the one that was produced by Public Health Scotland, with the very point that you're making, that instead of, you know, surviving till you were 75 and being ill from 65 to 75, you're now becoming unwell at 55 and you're dying at 65. I can't remember the exact figures, but basically that was the trend. You're becoming unwell and the quality of your life was deteriorating much in the areas of deprivation. So it is a whole system response to this. It's not just general practice, but it's the issues around stroke and peripheral arterial disease look particularly stark on this table. And I don't know why that there's been, I don't know if that's a spike in strokes or whether that's just been growing year on year. And I think Public Health, Emma Fletcher, has looked at it. I think she's produced a paper or done some investigation into it. that right, David?
Yeah, it's a complex area.
Yes, she's here.
Yeah.
Sorry. Sorry, Emma. Did you want to come in here?
It was just to say that we have looked into and worked with secondary care clinicians around understanding the stroke picture, but I mean, it reflects the increasing multi-morbidity across the whole population, unfortunately, due to a number of different reasons. But I'll pass back to David. Thanks.
Thanks, Emma. David?
Yeah, as I said, it's complex. You've got an aging population. You've got specific triggers that result in higher stroke prevalence. You've got an increased burden of metabolic disease associated with obesity. So there are lots of reasons why stroke prevalence increases. There are some things that countervailing. We do have reducing smoking rates, but I think where we are just now is the result of many inputs.
Okay, thank you, David. I've got a couple of hands up with questions. I've got Sam, and then I've got Dorothy. Sam?
Yes, thanks, Pat. And as you said, I can't remember in all my time in general practice in Dundee having read such a detailed document, which is not a positive. Because there's so much to all the team who put into it. There's so much good stuff in it, and a couple of things I wanted just to pick up on, which I remember from my time. The sphere of influence. I think, David, as you said, that is so important, because I can remember trying to have teams with different employers and running into barriers. And if anything would be done to help that be reduced or be eliminated, then that only can be positive for the people of Dundee. So that was great. And the other bits, I was page 20. You're talking about the working group to oversee it and the action plan. And I just want to know as to what the progress is on that happening. Yeah, that's all. But overall, very refreshing to read, and thank you.
Thanks, Sam. Did you want to comment there, David?
I'll let Shona come in on that one.
Okay.
Yeah, we've now that we've kind of got more of a primary care team, it's really good to be in a position, and Sam and Pat's comments are helpful, because a lot of what we've done up till now has been very reactive. So it's fantastic to have had Julia's expertise to pull this together, and she's done a really, really good job, including the engagement that we've done. So that the clinical management team that we now have will look at that, but some of them will be, again, a bit like the work that Emma described, will be specific groups will need to sit underneath that. So I guess we were seen today as a staging point, and then once we'd got support from the IJB, we can look at how we move this forward. Obviously, it needs to dovetail into the Tayside primary care strategy and the wider contractors, and we've been linking around the Tayside work, so we'll continue to do that. These two things dovetail, and the information goes in both directions.
Thanks, Shona.
Thanks, Shona.
Okay, I've got Dorothy, and then I've got Donald. Dorothy?
Thanks, Pat. I would just like to record, with my other hat on as Secretary of Dundee Pensioners Forum, we're grateful to Julia for her engagement with our group in the preparation of this report. It's a very useful report and interesting, and I think there's a huge challenge here, communications challenge, to get the message over, particularly to older people, that, you know, it's not always the GP they need to see. There are other health professionals within the practice, you know, and that's a cultural thing that we need to get that message over to older people. You know, you don't have to see your GP every time something's wrong with you. And it's no surprise that access, this certainly comes out in our meetings with the Pensioners Forum. And there's also a huge communication, I think, to be done around health prevention and self-care, you know, for older people. We're stuck in that place where you phone your doctor, you know, and the doctor will sort everything. And of course, we're all dying out now, you know. In a few years' time, you won't have that problem, because younger people coming up will be used to, you know, different ways of working. But It's a very interesting and useful report, and I just wanted to say thanks to Julia for her engagement and just to outline that communication message that needs to be done, especially with older people.
Thanks, Dorothy. That's very helpful comments as well. And I think the committee echoes your sentiments around the engagement work. It's not always easy to do engagement work, and it's hard to get people there, and it's hard to get a broad and balanced, view. So well done, Julia, for going out and making the effort to engage with lots of groups and lots of stakeholders. That's not always an easy job. I've got Donald, and then I've got Ken. Donald.
Thanks, Pat. And yeah, I agree with Dorothy. Really, it's a very good, thorough, well thought through document. I'm grateful for that. But there's no getting away from the fact that our GP practices across Dundee are under pressure, and I think every time one closes, that then places more pressure on those that are left. So what was in my mind was very much what are we able to do that can help to reduce that pressure. Now, one of the things that there wasn't much discussion about the role of the community pharmacies in the paper, and I know some things, yeah, you need to see your GP, but I just wonder to what extent the community pharmacies can help to take up the burden, and then to what extent within Dundee are they well placed to take up that burden? Because certainly wearing another hat as chair of pharmacy practices committee, I've been chairing that committee for over 3 years, and I haven't seen a single application for a new pharmacy in Dundee during that time. So, are we adequately covered for the present or indeed the future? So really, how do pharmacies and GPs interact?
Thank you, Donald. Before I ask David and Shona to answer that, there is also the issue of prescribing pharmacists, and again, the paper doesn't really refer to that, Julia, but it's a great paper, and we're really very, very pleased with it. These are maybe just helpful comments to think about for going forward, because I know in Glasgow we have a lot of pharmacies, not a lot, but we do have pharmacies now that are prescribing, and so that means that people don't need to go to their GP. They can just go along, get their antibiotics for their chest infection or whatever it is from the local pharmacy, and you never need to see the GP. Have we got that, and has that made a difference, and would want to promote that? We'll bring in David first and then Shona.
So absolutely, we've got a number of independent prescribers within pharmacy and a number of supplementary prescribers. The difference being that a supplementary prescriber can prescribe according to a protocol, and there are a number of protocols that support, for example, the prescription of antibiotics for urinary tract infections. We also have an active minor ailments scheme that provides direct access to medicines which can be prescribed but are also available over the counter, like Calpol for hot kids, or creams and ointments for eczema. And absolutely, there's ongoing work to try and train up more independent pharmacists. We have a reasonably broad coverage of pharmacies within Dundee, so we haven't had any new recently. But we are managing to retain services, which is not necessarily easy to do. I know that in Angus, they've unfortunately had some issues with that. And we have evening hours up until 9 o'clock covered from premises in Albert Street, which is handy. So absolutely, pharmacy in community pharmacy is pretty core to supporting general practice, and quite commonly practices will signpost to it, and quite commonly patients will now present as their first issue to pharmacy. We have ongoing work between our out of hours and pharmacies as well to ensure that there's good access to community pharmacists during the out of hours period, so that they can get direct professional to professional support. And we have been working with practices to try and get bypass numbers and so forth, so that if there are queries that pharmacies can get directly in touch. Obviously, additional to this, we have practice pharmacists who are pretty core to making sure that medicines are prescribed safely, particularly at transitions where someone comes home from hospital or is moving into a care setting. So I think we're well integrated with the profession, and we are seeking to expand that further.
Okay, thank you, David. Shona, did you want to come in as well on some of the comments that were made?
Yeah, I mean, David's covered a lot. One of the difficulties with the paper, and Julia alluded to that, is how broad do we make this? Because it's a similar discussion to the mental health and wellbeing. There's actually a huge amount in the community that's there that supports and links through general practice because of the breadth of our general practice primary care teams. Absolutely agree, Donald. Community pharmacy is a huge resource. Andrew Radley's been working on the pharmacy plan, and we've worked alongside Andrew and looked at how that dovetails with work locally. That's really helpful. There have been some capacity issues in community pharmacy, and particularly at that more advanced prescribing level. So I know that Diane Robertson's doing a lot in terms of developing independent prescribers to be able to support people accessing pharmacy around a broader range of things. But at the moment it's a little bit hit and miss, and as a real dilemma for practices, you don't want to direct people to community pharmacy and then there's not a pharmacist there that can prescribe for you on that particular day, and then you get disenchanted about it and you end up back at the practice asking for an appointment, and then you've been there 2 or 3 times and you've waited in the queue 2 or 3 times. So sometimes it's when you get to that tipping point that actually makes things feasible, but we do use that resource a lot, and again hopefully there'll be a bit more in the overall Tayside strategy, because obviously community pharmacy is one of our key independent contractors. The number of pharmacies, we've got more pharmacies than we do practices, and again I think probably the focus is on trying to keep those teams stable and have capacity within those teams, because recruiting skilled pharmacists is really difficult. As we know, people move from community pharmacy to our practice pharmacy team to hospital and back, so it's a market where there's lots of opportunities for people to move around, but a lot of development and work happening in the background to ensure closer integration. Things like access to portal for pharmacists is happening, so they've got more clinical information to inform their prescribing and their decision making. So I absolutely fundamentally do support this. We've just kept this particular strategy fairly focused, I think. Does that help?
Yes, it does help. Thank you. It's good. I think overall we feel that it's a really excellent paper, and Julia and the team are to be congratulated on that and all the work that's gone into it. I've got Ken with his hand up.
Yeah, thanks. This is something that I've mentioned before, and it's not only a personal bugbear of mine, but it's a general concern for the health of the population. And David mentioned it when he was talking, and it's this. I don't know what percentage of practices are still doing the 8 a.m. phone call to get an appointment. But I have really serious concerns about that, and I think it's interesting that far and away the highest priority in terms of the priorities of the stakeholder group were access to GP services. Look, a bit surprised that population health was at zero, given the preventive work we need to be doing over the next few years. And I think this 8 a.m. appointment system really impacts on the strategic work programme, where we're trying to improve access to services, focus on prevention and address inequality and inequity, because I think it's difficult enough for people who don't have drug or alcohol problems or mental health problems to fit an 8 o'clock phone call that might last for an hour around their day. So can the members of this committee imagine how difficult it is if your life is in chaos through drug or alcohol use or a mental health problem? And I have some experience of this. I worked with homeless people in Dundee for many, many years, people who were sleeping on the streets, rough sleepers. And we'd always try to get them an appointment the next day. And we'd be able to get them the appointment, but it'd be very specific. It'd be 9 o'clock, 9:30, 10 o'clock. And the number of times that people didn't turn up for these appointments and get the help they needed was really, really disappointing because it was too rigid. Because most of the people who were sleeping on the streets at that time had drug problems or alcohol problems or mental health problems, and they just couldn't fit around a system with that level of rigidity. And I just want to really emphasise that, given what I've said about access being highlighted as the main area of concern, this is something that I really wish GPs would reassess. As I say, I don't know how many GP services are still doing this, but it just doesn't work for people who have chaotic lifestyles. And I think it's going to have a knock-on effect. It's going to impact on inequalities and etc. So I just wanted to really make that point.
Sure.
Okay.
If I just
Okay,
come
David, yeah.
back on that quickly, I know that David Wilson's wanting to come in too. Very useful points. Absolutely recognise the issues. There are two main forms of access. There's, I guess, immediate access, and then there's access where you plan a long time in the future. I know that 3 weeks next Tuesday, I've got a slot in my diary. That's when I want my appointment, or I've got an emergency problem that needs to be dealt with today. Tends to be that practices that look after deprived areas put a premium on more direct access. You phone on the day, you'll get seen on the day. That then causes problems for those who want the appointment 3 weeks next Tuesday. The specific group that you're referring to, which is a sort of chaotic people, if they're given an appointment slot the next day at a specific time, which is that pre-booked stuff that you're referring to, they often don't turn up, which is why having the ability to access on the day is fine. They're not going to come 3 weeks next Tuesday. That's a great way of resolving a lack of access problem. You give them an appointment that you know they're not going to go to. It doesn't really help anyone. I think the main issue that you bring out there is that there are constraints on our capacity. So absolutely, you want to be able to deal with people who need to be dealt with. And so you need to have that emergency stream coming through, but you also need to be able to give people certainty. And beyond that, there are those vulnerable groups for whom you need to give them some form of priority access, so that you can make sure that it's captured, it doesn't go around the system creating chaos. So I guess there are sort of three main bits there that we're trying to do. And it's really difficult to square that circle. Now, my practice, you can get a pre-booked appointment if you want. See you at 7:30 on a Thursday morning. I'll give you a pre-booked appointment for 2 weeks. Well, probably not 2 weeks because it's going to be Christmas time at that point. But as I said, we can do that. We can also see you that day if you want. And we've got a duty doctor system that means that if anyone does call and they've got an emergency, they'll get dealt with. Not every practice is like that. We do have a set of GP access principles. We have put them around all practices. And I think practices will come with different solutions that will in part relate to the demographics of their patient need. We perhaps have less priority on being able to pre-book an appointment because my practice has the fourth most deprived population in Tayside. Brighty Ferry practices, I know you can get a pre-booked appointment for 4 weeks' time if you want, but it's a bit of a hassle waiting for the 4 weeks. As I said, there is a difficult circle to square. We have general advice there to try and help practices along. Having patients phone multiple times to be disappointed to finally achieve a appointment slot doesn't help anyone. You get an irritated patient who doesn't enjoy that experience. So trying to find ways in where we can get the right person into the right appointment slot at the right time is absolutely ideal. And a lot of that is about trying to look at the work streams that are coming through to make sure that only those things that need to go to the GP go to the GP, and making sure that we're care navigating at the earliest stage. So if what you need is an appointment with a physio, that you go direct to the physio. If what you need is an appointment with the PALMS worker that you can go straight to that. That if what you have is a problem that's best sorted out through sources of support, that's the thing that you get. So I think the bottom end of it is I can't tell you that we're necessarily going to fix it and that we can get away from folk phoning at 8 o'clock. We are trying to do the best thing that we can do with the resources that we've got. Sorry, I went on a bit there.
No, I think I totally accept what you're saying, and you know, it's not like you can't legislate. I mean, this is a strategy and it's really good paper, and it highlights all the challenges, but you can't legislate. There's certain things that are kind of out with our control. I mean, these are independent practitioners, and you know, if they have to run their business the way that they think works for them and works for their patients. I'm going to bring in David Wilson and then Shona. David?
Yes, yeah, thanks, Pat. I was just really to echo some of what David said in terms of things on the ground. I don't think there is a one-size-fits-all system that every practice is going to be able to adopt, because every practice has got its own challenges, be that staffing, workforce, etc., let alone their patient demographic. And it is that balance of how much do you offer pre-bookable, Ken, versus emergency on the day, and finding that balance. There is work going on at cluster level and at practice level. At Lockheed, we've done the primary care access programme. I'm having a further meeting with a quality improvement advisor about pulling that together, which will then be shared across my cluster, but also across the Dundee clusters, in terms of looking at how we can change our accessibility to patients in terms of the types of appointments that we offer, be that on the day, pre-bookable phone calls, pre-bookable face-to-faces. But I think it is a challenge that a lot of practices are facing and are aware of. But I don't think that, as David said, squaring that circle is going to be an easy thing. But I think practices are aware of it, and we're trying to do things about it, is what I would say.
Yeah, I think we accept that, and I think there's a lot of really good work in progress. It's not going to be an overnight solution. I mean, the workforce issues are not, you know, medical schools are taking in more students. They're talking about a 6th and possibly a 7th medical school in Scotland, with St Andrews being one and Inverness, University of the Highlands being the other. The GEMS programme is taking in a large number of students every year. But then we hit the pressures of medical education and not having enough medical educators, and obviously we don't pay them enough money. So it's not an attractive thing for people to get into. We don't have enough library facilities. So it's not an easy solution, the workforce solution either. I'm very conscious of that in terms of your sustainability long term. Shona?
I can't add much to what David and David have said. I think Ken's point, though, about we don't know how many practices are working in this way is a really valid one. And I think maybe there's something now that we've got the strategy about, well, how do we unpick this a little bit to actually find out. Now, David's describing something that will look at that a little bit at cluster level, and we will tap into that. The other thing is just about IT technology, phone systems. So again, we're doing some work trying to look at, is there little bits, and they're probably tiny little chips that we can get off the ice block that might help with some of this. So we're aware from some discussions with Lothian that they've some of their practices have a phone system that when you phone, the system recognises your phone number. It highlights to admin staff who you are, so they're in your clinical record. When you get the receptionist, you can look, people can be prioritised and pulled out the queue. So if it's somebody who's maybe sort of at the end of their life, if they were phoning, they would be able to be prioritised. So we are trying to look more broadly around other little things that might help with some of this. But I think we will look to undertake just finding out in a bit more detail from practices, and then how do we work with them to maybe do a little bit of the chips if we can.
Yeah, a bit of a mapping exercise, Shona.
I've raised my hand. I just want to come back in and thank all three of you for the responses, and also to say that I fully acknowledge the pressures that GP practices are under with the pandemic, and now we have, of course, unfortunately, GP practices closing. I acknowledge the pressures, but I just feel that first hurdle that people have to cross is I think the bar's set too high. But thanks very much for your response.
Okay, thanks, Ken. Okay, if there are no more questions, we are asked to approve this GP practice strategy and to progress with the activities set out in the 5-year strategic work programme. Agree that half-yearly updates are brought back to the IJB as this strategy is implemented. Everybody's happy with that. I want to thank Julia and David, Shona, and others who've contributed today, and those who have contributed and led in the strategy development. I think it's a landmark piece of work for this IJB, and we're really delighted, Julia, to see it here today. And you know, although we asked lots of questions and some of them are not easy to answer, I think we're making real progress and real headway. So very well done for not losing the plot and keeping going with it. And well done. It's really good piece of work. I think we're really pleased with it. Thank you.
Thank you.
Okay. So that concludes that item. We're now moving on, item 6. I have had coffee passed to me very kindly by my other half, but I'm conscious that I've kept you all in front of the screen. If you want 5 minutes now for a cup of coffee and a comfort break, we can resume at 5 to 12 and keep going with the agenda if everyone's happy with that. Okay. We'll press on then, if I may, with item number 7, which is the winter plan. And I don't know if that's Dave or who's presenting that. No.
I think Lynn's doing that.
Oh, sorry, Lynn. My apologies. You're Queen of the Winter Plan.
Or something like that. Yeah.
Something like that. My apologies, Lynn.
She is the winter plan, Pat.
She is the winter plan. She's keeping us all organised, Jenny, is she?
I'm able to smile because we're actually in a really good position, so I'll hopefully reflect that as we go through. So the winter plan, it's obviously our annual Tayside wide winter plan, and our covering report is to specifically tell you what the contribution has been from the Dundee Health and Social Care Partnership. So the plan differs this year from previous plans because it doesn't come with a budget. So we have traditionally had some financial input to help us to enhance our services, and that hasn't been the case this year. So many of the things that we are doing to contribute to continued capacity and flow comes as a very much business as usual approach. And that's, again, I'll reflect that as I go through some of the key measures. The key message, I think, in the Tayside plan this year is a really robust whole system collegiate approach, and again that reflects the continuing maturity in the relationships across the 3 partnerships and into NHS Tayside that I think we're quite proud of. And so real attempts made over the last 2 or 3 years in particular to see whole system pathways of care and how that impacts on patients across the whole system, which I think strengthens our authority, if you like, in the partnerships, because acute have now realised that they need to look out to what we're doing out in communities in order to make sure it's impacting positively on patient flow and then patient settings. So a real good collaboration across the whole system, and that's been governed through primarily a winter advisory group that's been set up within NHS Tayside that covers all of the partners and that I represent Dundee on. And the main work that flows through that contributes to this is governed through the Urgent and Unscheduled Care Board. And again, I'll go on and see what the main pieces of business as usual work are through that. The other key message within the winter plan is that in its entirety, everything we do is designed to deliver care as close to the person's home as possible. So a real move away from inpatient services, which really puts the spotlight on our mainstream and urgent care services, and I hope links with some of the previous presentations that Shona gave around how we support primary care to try to prevent admission. So a real focus on care closer to home. In terms of the Urgent and Unscheduled Care Board work streams, which is our main business as usual, they have 4 main work streams, all of which are contributing throughout the year to making sure that the winter plan works. So one of them is community urgent care, and that's our main focus in the partnerships, because that's obviously about how we deliver our care. So I'll talk to that in more detail. But the others are optimising urgent and unscheduled care access. So that relates to all of the front door areas within the hospital, using the Flow Navigation Centre more proactively to try to provide alternatives to admission, for instance, and optimising inpatient flow, which again in Dundee we have a very significant input to, because we now have an arrangement with our acute colleagues that we have a senior nurse for urgent and unscheduled care who is specifically leading on that work to optimise inpatient flow, who is paid for through the acute hospital, but is actually hosted and managed by myself in the Dundee Partnership. So again, a real good example of mature collaborative working. And the other work stream is Performance 95, which really focuses on maintaining the ED performance, maintaining the 4-hour target, which is the sort of fundamental performance measure for all of our performance across the other services. And you'll probably all know from the publicity in the past week that we are now the best performing health board in Scotland in terms of maintaining the 4-hour target. So again, an indication that these work streams and the focus of the work through urgent and unscheduled care is really working and being successful. So in terms of the Dundee approach, again, most of the work that we are doing to contribute would sit within the work stream that is now called Community Urgent Care, and that fits with the National Urgent and Unscheduled Care Collaborative, and how we've then interpreted that locally and what the focus of our work is. So much of this is things that you will have already heard about through individual and more detailed reports that have come through the IJB throughout the year. So just some headlines. We continue to fund interim care home placements on a business as usual approach. The numbers of those are falling, which is a good thing. That was used as a really a COVID mechanism when we didn't have access to social care. So it was obviously pushing people onto the wrong pathways, and it's not something that we wanted to maintain, but it was something that we had to do to protect hospital beds. So we're seeing those figures dropping, and that's a good thing, and that's largely due to the lots of the improvements that have taken place in efficiency within the social care sector. And I know that a paper has come to the IJB before, which has outlined those. Dave will highlight also that has contributed to our continued overspending in social care, but is clearly contributing to better outcomes and better flow through our services for people. So that's interim care home placements. We now have a partnership oversight report, which is published every Friday, and that gives a higher level overview of performance across the partnership. Many people on the IJB will probably receive that. One of the things in there is how our performance is going against delayed discharge, but it gives an indication of what our RAG status is as a partnership. And that then feeds into a whole system NHS Tayside-wide heat map, which we've developed over the last 2 to 3 years across Tayside to demonstrate where the hot points are across the whole system. So we can quite clearly see now that if there is a pressure point in the inpatient service, we know that we can predict we will likely have a hotspot in community services roughly a fortnight later because of the flow of patients. So that heat map is really helping us to plan services more effectively. Part of the role of the senior nurse that I described earlier, who's funded through acute but managed by us, is about a really intensive approach to continuing to implement our plan date of discharge and discharge to assess models across all hospital wards in Tayside. So although that member of staff is hosted within Dundee, she has a Tayside-wide role. And that work to optimise discharge is about setting actions at ward level, so really at operational level, to ensure that each ward area is meeting their benchmark length of stay target. And again, we can bring this in more detail to the board if it's of use, but the results from that are phenomenal. Actually, most of the ward areas where this work is being targeted are if not meeting their national benchmark length of stay, exceeding it. Of particular interest for us in Dundee is the work that's being done around optimising patient flow in the Royal Victoria Community Hospital site, where their length of stay was identified as a problem in terms of allowing patients to flow and maintaining supply and demand. So from a position, I think in August, of around 60 days of length of stay average in Royal Victoria, our benchmark is 28. That's what we're trying to achieve. And this month we are officially at 29. So that's fantastic performance, demonstrates the impact of the improvement work. Still work to be done, but obviously going in the right direction. Much of our focus around what was care closer to home as a national work stream and is now urgent community care is around expanding and developing our existing Dundee Enhanced Care at Home service, which again I think has come in previous IJB papers. So that really is a means of supporting primary care, trying to prevent admission to hospital by providing enhanced medical, clinical, nursing services in the community wherever possible, and identifying the deteriorating patient early. So some of the improvement work around that started for winter has been an extended ANP hours rota, which extends into the out of hours period. We've identified that some of the inappropriate admissions to hospital that tend to lead to longer stays come in that 5 to 7 o'clock in the evening out of hours period, just as mainstream services are closing down. So we're doing an extended hours test at the moment, where the ANP will be present in out of hours to support the out of hours clinicians and provide an alternative home-based assessment. We also have put in place a number of improvement measures to try to get back to our pre-COVID approach of looking at what we would call green referrals. So during COVID, due to demand, we had to really focus on our amber and red level referrals, so people who were at risk of hospital admission within the next 24 hours and were some of them quite seriously and acutely ill. What we have now done is realigned our services to try and reinvigorate our GP cluster enhanced care meetings, so that we're identifying patients early and adopting an early intervention approach. And that hopefully will start to provide services to people earlier to try to prevent the deterioration that leads to hospital admission. Bit of a slow burner in terms of impact, because that's obviously trying to really turn around a culture that's developed during COVID, but I think that will pay some dividends in the new year and hopefully will also provide some support to GP services. In terms of the inpatient improvement work, the discharge team over this past year have become fully embedded across patient specialist pathways on ward areas. And we have, although this report has just been written, we've already moved on, which again demonstrates the speed of change and improvement in the inpatient setting. So we are at the moment testing an enhanced flow coordinator role within the discharge team. So for example, we, because of demand, now have 5 inpatient areas in 9 Wells alone that manage medicine for the elderly patients. So there's a need for us to actually manage flow into the right areas within one hospital base, rather than between hospital bases and out into community settings. So that flow coordinator role is in development, being tested, and is being seen collaboratively in the inpatient setting as a great approach, and again something that Dundee is leading on. So that's a very recent improvement measure. We have worked with our colleagues in acute to make sure that we all have winter resilience action cards in place, so that each of the leaders across the various services have now got an app on their phones, with the idea that if there is an escalation in the business continuity plan for 9 Wells, that there is an alert to myself and other lucky people that we can then activate the action cards that we've put in place for key services, so that there is a really clear communication strategy for when we need to escalate into the next level of our individual service business continuity plans. So I think that that's a further development of the collegiate whole system response that has been developed this year. The key things that we have been asked as a partnership to contribute to are that length of stay in the community hospital, which, as I said, we are well on the way to achieving, but also maintaining a green RAG status against the locally agreed targets for delayed discharge. And very pleased to say, again, against all the odds in the middle of winter, but we have just this past 2 weeks gotten to green RAG status against all our indicators. So both for non-complex delays across the city, but also in terms of the numbers of acute delays, we are now sitting in green. Our colleagues in Angus are also green. Some problems with our colleagues in Perth and Kinross, but our performance in Dundee's excellent in Tayside. The point being made in the operational leadership team meeting that the performance that's been publicised over the past week or so in the national press, the Tayside being the best performing board for the ED performance target, must be seen in conjunction with the work that we've done in the partnership to maintain that green RAG status. So a really clear indication of an understanding across the system of the contribution that we have made to getting to that target point. So that's a really quick run through of many of the business as usual measures that we are taking to contribute to the winter plan. Just a small note, sorry, I know Vicky wants to come in. The next escalation point in terms of our predicted activity in the inpatient setting was due to start on the 18th of December, which would be next week. But we've just heard this morning through our winter contingency meeting that COVID activity in the community has apparently risen quite significantly, which is leading us to think that there will be an escalation of the contingency plan on the 15th rather than the 18th. So we, I think, need to brace ourselves, and that probably introduces some strains for us in the partnership, particularly, for instance, on inpatient AHP services, which we host in Dundee, because that will mean extra surge beds opening on the Nine Wells site with no additional AHP staff to manage the patients through those beds. So just a note that activity is increasing in the community. Thank you.
Okay, thanks, Lynn. Thank you for that. I see Vicky's hands up, so I think Vicky maybe wants to come in on the back of that presentation. Thank you.
Yeah, thank you, Chair, and thank you, Lynn. And I must start with an apology, because I'm conscious that the independent chairs who are contributing to the next report have got to leave shortly, so we'll probably have limited time for discussion. But I really just wanted to share with the committee the response that we had at the NHS Tayside Executive Leadership Team on Monday. We presented the winter report, but also in addition to that, we had the chairs of the Unscheduled Care Board and Planned Care Board. Jenny is one of the co-chairs of the Planned Care Board, to present all of the information that Lynn has just shared with us, but also to share current performance levels. And I think it's noteworthy to say that Dundee's current position, particularly with delayed discharge, is the best it has been for nearly 4 or 5 years. The fact that we had, as of the census date last week, only 4 patients in delay in Nine Wells Hospital is absolutely phenomenal. And I think it's due to all of the hard work that the teams have done across the entire system, not necessarily just within the Health and Social Care Partnership, around patient pathways. And just to re-emphasise that falls against a backdrop of significantly increased demand across the entire system, but in particular, a demand which has risen for home care in the region of 70 to 80%. So that's really, really significant in terms of the performance, not just of the team that Lynn represents today, but the entire system, to make sure that we are trying to provide the most efficient and effective patient pathways that we can across the system. So apologies for taking up that time, Chair. I just wanted to restate that and pass on all my thanks to those involved.
Thanks, Vicky. It is an impressive piece of work. It's not just the written down work; it's the actual fact that that's what's happening on the ground, you know. And I think we've got real good whole system working between, you know, urgent care, unscheduled care, ED performance, and the work that's going on in primary care and social care. So well done to everybody involved, and thank you, Lynn, for all your efforts in that regard. If there are no other questions on this paper? No. So we are asked to approve and endorse this winter plan, which is part of the NHS Tayside partner organisations overall plan, and note the ongoing whole system collaboration. I hope that things are not too difficult over the winter period, and I'm sure your plan is robust and has resilience built into it, Lynn. So we're grateful for that, and I'm sure the people of Dundee are benefiting from all the hard work. Okay, thank you for that. Okay, Arlene, moving on to agenda item number 8, which is the Protecting People Committee's annual report. And obviously a lot of work has gone into this as well. So this is the annual report. I've seen it before, I've read it in quite a lot of detail. There's a lot of work, there's a lot to take in, and you don't realise how much is involved in this. Who's presenting? Catherine, are you? No?
Yeah, I'll make a couple of opening comments, Pat, but I'll keep it brief.
Just keep it short, yeah. Thanks,
Catherine. So Elaine Torrance and Alan Small are on the call, unfortunately. Anne Hamilton's had to leave, and of course Emma Fletcher's here as one of the co-chairs of the Alcohol and Drug Partnership as well for any questions and comments. As you say, Pat, a familiar report. We bring this to the IJB every year, although maybe just a few differences to note this year. We have moved from having separate reports for each committee to having a single integrated Protecting People report for Dundee, accompanied by the standalone MAPA report. And actually that's helped us this year to bring forward the publication date. So all those reports were published at the end of October, which is significantly better for the public protection committees than it's been in previous years. And all credit to Aileen Milne, my colleague from the Protecting People team, who led the kind of preparation of the reports. This is also the first year that we've had a public-facing annual report for the Alcohol and Drug Partnership. You've previously seen the return to the Scottish Government, but this incorporates the kind of public report in it, and that was a key commitment in the ADP's strategic framework and delivery plan. So it's good to be able to kind of say that we've completed that commitment as well. And obviously the focus has been to try and make the reports a wee bit more accessible. There is a lot of information, Pat, as you say, so trying to get that in a format that's a little shorter and maybe more accessible for members of the public. Given that we've a briefing organised on Monday afternoon for members of the IJB alongside your colleagues from the City Council and NHS Tayside Board, and that the chairs will have the opportunity to present the contents of the report there, I wouldn't intend to say much about that other than the remarks that you've already said, Pat, and save the time for questions and comments that people would want to make in this kind of public setting.
Okay, thank you, Catherine. Have I got any questions from anybody? Dorothy, I'll bring you in, Dorothy.
It's not really a question. I just wanted to say I really like how some of the data in this report is presented. You know, this kind of layout. I find that really useful, and so, you know, it highlights specific areas, you know, that I can look more closely at. And I do like also accompanying this is the achievements, the detail on the achievements and challenges. I think that layout is excellent and very helpful to somebody like me. Thank you.
And I don't think it's just somebody like you, as you put it, Dorothy. I think we all need to have information like that laid out in a kind of digestible, it becomes digestible, doesn't it? You can take it on and you can remember what it looked like. So I think, yes, you have to be congratulated for putting it in a kind of more, you know, easily and accessible format. We appreciate that, I think. Have I got any questions on anything that's in the annual report? We're asked to note the production of this single integrated annual report, note the content of the Protecting People's Communities Committee and the Tayside MAPA Strategic Oversight Group. And also in the MAPA report as well, it had little case, little case studies, which I think just help you to put it in context for what it means to people's lives. Note the progress made in developing an effective partnership response to the needs of at-risk children and adults, and note the challenges and priority areas for action identified across the annual report and beyond. So there's a lot of reading there, a lot to digest, a lot of really good work, and we're grateful to be able to see that in a easily digestible format. Did you want to come back in, Dorothy?
Yeah, sorry, I did. One question did occur to me under the child protection information on page 263 of our bundle. It's the numbers of children added to and removed from the child protection register. I just don't understand how this works. 84 children added, 117 children removed, and leaving us with 27 children on the protection register. And I don't want a detailed explanation of this here, but if someone could maybe, you know, let me know how these numbers actually come together, that would be useful so that I can understand it better.
Okay, we're happy to take that out of the meeting. Yeah.
Yes.
Okay. Right.
Thank you.
That's no problem, Dorothy. So if everybody's happy with that on agenda item number 8, we agree the recommendations. We're happy to move on with that. Thank you for all your hard work on that. That moves us on to agenda item number 9, which is the Chief Social Workers Officer's annual report. There's a preamble paper and then the actual report itself. And I know Diane has come on screen to answer any questions we have on that. So I'll pass it over to you, Diane, to highlight anything you have particular issues on.
Yeah, I mean, I'll be very, very brief, Chair. The report, for people's information, you might not have seen it before, covers period 22 to 23. It's an annual overview of social work services, so it's not everything, it's not inclusive of everything, but an overview. It covers all social work services, children and family, community justice, and the health and social care partnership, but also third sector, where we might have social work staff working in that area. Also covers our social care services. So it's not intended to be an absolute, but more highlight the areas of activity within the last year as you sit within the functions of the Chief Social Work Officer, and it's really a reminder of the collective responsibility that we have for all vulnerable people in the city. I guess in essence this is one of the first reports that's moved away from the response to the pandemic and much more towards business as usual, but it still shows that we're continuing to adapt and really look to how we might respond to the capacity and the demands which are coming through to us as a result of the pandemic. So in essence still dealing with some of the aftermath of that. But we are showing that, as you've heard from all the papers today, that we continue to focus on improving services which take into account the risks that we're facing, to implement a value-driven social work approach and to ensure that people remain at the heart of the work that we do and continue to do that through partnership and collaboration. I will just touch very briefly on challenges. So we know that we have significant financial challenges facing us, and recruitment, while has improved, remains potentially an issue for us going forward across all of our service areas, and we see that issue around recruitment fluctuating depending on the areas of work that we're looking at as to whether we're stabilising or still in difficulties. But we also have things like the National Care Service. We're not yet clear what that's going to mean in relation to social work and social care services, and we know that information is again going through Parliament in terms of what the proposals might be around that. So we still wait to see what that will mean in terms of going forward. It will, if it does change, it will look at the models of service, the scrutiny of services, and the education of social work and social care. So really impactful on social work service in terms of what we do. I think I'm going to leave it at that, Chair, and I'm happy to take any questions. I'm very conscious of our time. Okay, thank you. That's helpful. Thank you, Diane. Have we got any questions on Diane's report? Any of the issues that are raised? It again was an interesting read to see the range and the breadth of work that goes on within social work around, you know, everything from, you know, care homes, community justice, asylum seeking children, fostering, adoption. I mean, it's a huge area of work in its own right. We are asked to note the content of the report, and that's really all we're asked to do today. We're not asked to fund anything or
change anything or initiate anything. We're just asked to note it. So if everyone, I don't see any hands up, if everyone's happy to note it, I just want to thank Diane and her team for bringing it forward, and it's an impressive piece of work. Thank you, Diane. Okay, that moves on to agenda item number 10, which is the workforce plan. And again, quite a lot of reading in this. So issues to be brought up. Whoever's presenting this is who's presenting this, Dave?
I think Jenny's on.
Jenny, there she is. You look as if you're in Norway at night time, Jenny, or somewhere. Iceland.
Oh, that is so far away from the truth. I'm in just outside Dundee and in the semi-daytime. Yeah, this is an update to the workforce plan. So we no longer have to submit a separate plan to the Scottish Government, but we have brought this updated plan just to make the IJB aware of where we've got to in terms of workforce planning. Okay. So it really just outlines the actions that we've been taking forward in relation to that. Happy to answer any questions on that.
Okay, right. Any questions for Jenny on the workforce plan? Has the and if I can ask you this, Jenny, has the increase in the hourly rate for social care assistance, has that affected the ability to recruit people? When it went up
in and of itself, no, but if you remember, we did the Fair Work thing. So what we'd found was happening historically was, although we were paying the hourly rate, people were not being deployed on shifts, so they were not getting the actual hourly rate, in fact. So the Fair Work that we underdid has made a huge difference, and you'll remember that Angie, in fact you were away at the time, brought the presentation about the outcomes of the Fair Work stuff that we'd done. So I think that's all playing very significantly into what we're seeing in terms of the reduction of unmet need in social care, which has gone, I think, from nearly 3,000 hours down to just over 500 this week.
That's excellent. That's really, from 3,000 to 500, it's huge, isn't it?
It's massive, and we can see how that's impacting now across the whole system, and you can see that, as Lynn alluded to earlier, starting to impact on the delay position. When that bit works, everything starts coming into
balance, doesn't it?
Yep.
Yeah, that's really excellent. I'm so pleased about that, because you were always thousands of hours down every week reporting that. So thank you for that, Jenny. I've got Donald and I've got Dorothy. So I'm going to bring Donald in first.
Yep, thanks, Pat. It's just a quick one. Thanks, Jenny. I mean, it's a helpful report, and I know we've always had this challenge that we don't have a workforce of our own. We have an NHS employed force and a Dundee City Council employed workforce. But I think my question was just in the section around progress and future plans. And you're talking about the workforce data working group, and they're going to be producing an integrated data dashboard for health and social care workforce. And it probably won't surprise you. I'd be really interested to see that, because I suppose I'm looking for a sense of timescale for having this, and also maybe a request that you don't wait until you've got the finished product, but maybe bring the template or the draft to us, so that we can have a look and maybe give our own input on it.
So that work's been done on a Tayside-wide basis, but led by Lindsay within the Dundee partnership, and it won't surprise you to know that it's not without its challenges. But Catherine, you'll maybe want to comment on this, the notes you've come on screen to.
Yeah, Jenny's given you the short version of that story. It's quite right, and the biggest challenge at the moment is getting a platform to host it on that everybody's happy with from an information governance perspective. So there are kind of real sticking points that we're working through in cooperation with the two partner bodies, and also doing that across Tayside then brings in additional council views, etc. So, but they are certainly trying to take an iterative approach and not aim for perfection before we do anything, and work with what we can and then build on that, Donald. So I wouldn't like to commit to a time scale without speaking to Lindsay, but I can have a chat with her and then try and get a sense back of when we think we might have something that's in a shareable format as well.
Yeah, could we maybe put that down as an action to come back on that? Because I know sometimes, particularly with the different relationships, it can sort of stretch off into the middle distance, not because of good intentions, but just because of the complexity. So yeah, if you could come back on that, please.
Okay, thank you. Dorothy, did you have your hand up? No.
Had a very similar question to Donald, so
Just
my
dealt
hand's
with
down
it.
again.
Okay, that's fine. What we're asked to do here is just note the update on the workforce plan. And I think if we're all happy, just to note that progress that's ongoing. And I'm pleased about the social care recruitment, really am. We did hope that that would have a big effect, and it has. So just goes to show, if you pay people a bit of extra money and make it a little bit more attractive, it's not an easy job to do, working. I remember working as a student in as a nurse. I was an auxiliary nurse in a psychogeriatric unit, and I worked there for 3 months to make some money as a student. And I tell you something, I really grew up in those 3 months. It was quite a salutary experience for me, and that's what led me into a career in the health service. But it's not an easy job, at all. And these people earn every single penny that they get. So I'm pleased that that's improved. That's good news. So we know agenda item 10. We move on then to agenda item 11, which is Dave's best value report. Best value arrangements for the IJB, for the Health and Social Care Partnership. Dave?
Yeah, just very briefly on this one, the report kind of sets out our kind of assessment against the kind of Scottish Government's best value framework that's in place. So we've kind of looked at our sort of governance arrangements and other areas within that framework, and they kind of provided the evidence back in terms of what it, in terms of those particular kind of measures and expected outcomes, what we actually have in place for that, and our kind of assessment is that we are kind of demonstrating best value, as we did at the last kind of report that we took. The aim is to kind of have this on an annual basis, to kind of as in terms of the framework that's in place. So no, expect this one to be an annual best value overview to be provided.
Okay. Any comments or questions for Dave on best value? Everybody's best interest to make the best of government money that's come to the government, that we are responsible for spending, making sure it's spent wisely, make sure that there's good audit and financial probity around the effective use of resources. So there's quite a number of things in the paper which I think give us assurance that that work is all within our framework. I don't know if anyone's got any questions for Dave on this. Section on communities and collaborative working, and then there's a bit on measured expected outcome and evidence of the outcome. So again, quite a difficult area to manage in some ways. Okay, if everyone's happy with that, we're just asked to note the content of the report and note the outcome of the assessment provides assurance that best value is being achieved through our governance arrangements and activities. If everyone is happy with that, we will move on. So we've completed on agenda item 11. That moves us on to the budget outlook, item number 12, which we had a session on. Dave took us through all the ins and outs of the budget position. And obviously we're still waiting on Scottish Government to announce on the 19th what their proposed position will be going forward into the next financial year. Do you want to comment on anything here, Dave?
Yeah, just very briefly, given I know that not everybody on the call managed to make the development session last week, so just to get a very broad overview. So the figures that are kind of set within the report are still indicative at this stage. They are kind of based on our best assumptions and best estimates at the moment. As you said, Pat, the Scottish Government's budget now, so it will be the 19th. That will give us some level of clarity in terms of the actual funding, but actually the detail of that really starts to kind of flow through over the kind of weeks after that. So it tends to be kind of early January before we get a really good kind of idea around the kind of funding, how it's going to be kind of allocated out. and what's if there's any additional funding streams coming through, what the kind of manner in which they'll be distributed as well. So it is kind of very much an estimate. It is our kind of estimate at the moment that we'll have over £19 million worth of additional pressures, or kind of pressures from this year as well, kind of flowing into next year in terms of a recurring basis. And then new pressures that we expect to kind of see over the course of 24-25. So we have made assumptions on various kind of uplifts coming in. The main one will actually be around, you kind of touched on it earlier, Pat, around the adult social care pay. So they kind of increase up from £10.90 an hour up to £12 an hour. So Scottish Government funded and Scottish Government national policy on that. So that kind of should give us sufficient resource, we hope, to kind of cover the implementation of the policy as required by Scottish Government. We still kind of we'll continue to work with Dundee City Council and NHS Tayside finance in terms of kind of refining our assumptions as we go through, and like I say, based on the best estimates that we've got. We do, as you know, have other development sessions in the diaries now into kind of January, February, March. We'll bring a kind of formal paper back to the IJB meeting in February, kind of outlining what the budget offer from both the partner bodies will be and what the implications are for ourselves within the IJB, before we then take a final paper at March to hopefully agree a kind of budget for the 24-25 financial year. So that's probably all I want to kind of add to just now, but kind of happy to take any questions.
Okay, any questions on the budget paper? I think it's good that we've got more sessions for the IJB as we go through the financial year. Sometimes this is such a big issue and such a big item that it's hard for us to cover it in the committee meeting itself. So I think, and it also allows us to ask the daft lassie questions in a safe space. So I think that's really helpful, Dave, and thank you for doing that. There's only one question, and it was a question that came up at another meeting I was at, and some of you will have heard this before, and that's this issue of how we arrive at not so much the budget, but when we're making we're making decisions or we're making recommendations about the savings, and I just kind of leave you with this. It's what tends to happen in organisations is the people who do the work come up with a range of recommendations, options, if you like. Well, they're not options. Quite often they're just things that they think will work, and then they add it all up and they say this is going to be 38 million or 16 million or whatever it is. And I think, we have tried it to be a bit more inclusive in lots of ways, but I do wonder if maybe going forward, if we need to think maybe more about options. What are the options? Because sometimes I think some of these options have got they're going to be quite difficult to explain to the public, and I think also it's got to link up with that issue of the risk appetite of the IJB. What do the IJB want to take risks on, and what do they not? What's important to them, and what's not important but less important? So I'll just leave you with that, because I won't be here to be doing that work with you, but I just think that, I've reflected on a number of things recently, and I think maybe going forward that's something that organisations need to think about, because it's a governance issue that we're right behind these decisions, and we're not sort of presented with not a fait accompli, but a list of things which then we're rubber stamping, as opposed to really thinking through the ins and outs of what that means to the communities that we're there to serve. I don't know if other people think that, but it's just come to me recently that maybe we need to do this in a slightly different way. And it came up at the health board, I'll be honest, and it's come up, I think, in other organisations I've worked with. So Dave, do you want to come in there?
Yeah, I mean, absolutely, Pat. I mean, that is the approach that we want to take. That's why we've got the kind of development sessions, because it would be a kind of case of, you know, as officers, we have a responsibility to kind of provide to you as members a kind of whole range of options that you need to be considering in light of a number of factors, including, you know, as you say, the risk appetite side of things, but also the delivery of the strategic plan as well, because, you know, as everybody's aware, public sector bodies are going to have a lot of difficult decisions to make, given the kind of projected kind of position for kind of public sector finances in Scotland over the next kind of year. So yeah, the expectation is that we would be doing that in partnership, and obviously, given there would be both kind of council and NHS services, provided that kind of discussion and consultation would extend kind of wider. So that we're not just in a position of the IJB has decided this and kind of land something on the NHS board and the council, for instance. So there is a kind of pretty intense kind of period kind of coming ahead in terms of development of that budget. But absolutely kind of engagement and consultation with yourselves and with partner bodies is key to that.
Okay, thank you, Dave. Okay, so what we're asked to do is note the content of the report. That includes the range of estimated cost pressures impacting on the delegated budget, including anticipated funding levels from partner bodies and the resultant projected budget shortfall. And we have done that. And note the budget development process for the IJBs for the 24-25 revenue budget is outlined in section 4.7, which is very clear how we're going forward in section 4.7. If the committee are happy with that, we will sign that off. That concludes on item 12 of the agenda. That takes us on to Dave's second paper, which is the financial monitoring position as at the 31st of October. Dave, back over to you.
Yeah, I'll pass over to Christine to this one. She's done all the work for us, so I'll pass over to Christine.
She's smiling. How can you be smiling?
I'm glad she is.
Well, the way that meeting has been sort of going so far, I was actually wondering whether I'd be really rushed at the last 2 minutes to try to get this done before everybody else had to rush off at 1 o'clock. But we've obviously motored through the last couple of papers, so hopefully this one doesn't have too many contentious comments, and everybody can get away for lunch relatively soon. This is again our standard paper that we bring. Every IJB gives us a financial position based on the figures up to the end of October, so 7 months of actual and 5 months of projected to the end of March. The financial outlook is currently projecting an overspend of £6.6 million for this financial year. Key themes remain the same as we've reported in previous papers. Although this is about £600,000 deterioration from the previous report that we brought at last IJB meeting, which was figures up to the end of August, I think, at that point. A couple of key points, and just a reminder, our financial plan for 23-24 always did include an anticipated gap of £3 million, and we've got ring-fenced reserves to fund that gap. That £3 million just ties in then to part of the figure, the cost pressures, the recurring cost pressures that Dave just highlighted into next year. So that £3 million continues into next year at this stage. But so £3 million will come from reserves that we know about, and the additional work that a lot of that Lynn covered in terms of increased cost and preparation for winter pressures, and the work that's already gone on so far will allow us that hopefully to tap into a further £1 million of earmarked reserves for winter pressures. So that does leave us with effectively an unfunded gap in terms of earmarked reserves of another 2.6 million based on these figures, which we'll need at the moment to come from our general reserves. But we as a collective health and social care partnership, we are continuing to work with operational managers and budget holders just to seek ways in terms of mitigating that overspend that we're looking at, and keeping that to an absolute minimum this year through the remainder of the financial year. One change that has increased the overspend in this year
was the ongoing negotiations in terms of the council staff pay award. At the time of writing this report and preparing these numbers, the negotiations were drawn to a conclusion, and they have obviously now concluded, and council staff have been paid their uplifted pay. But we did have to increase the provision in terms of the additional cost. So that's increased by a couple of £100,000 up to just over £1 million, or almost £1.1 million of additional cost pressure in terms of this financial year. And so linking back to the workforce plan and some of Diane's comments earlier, we do have a number of vacancies, or continue to have a number of vacancies across a number of areas, which is resulting in some underspends in some places, albeit some of that underspend from staffing is actually being utilised to cover agency staff, locum staff, and other supplementary staffing costs, which is therefore driving some other overspends because of that premium cost. Prescribing continues to cause us concerns, but although it seems to be stabilised in terms of what we were expecting it to be. So we do have an overspend on that, a lot of that to do with costs, activity, demand, and short supply issues. We are aware that there is a continued delay in actually receiving information from the prescribing due to a national IT system change. So there's a bit of a risk in terms of those numbers. So I think we're 3 or 4 months behind rather than the normal 2 months. So we're monitoring that when I'm working with Tayside colleagues in prescribing and primary care to monitor that. And there's a unexpected cost pressure this year in terms of continuing cost pressure in terms of GP out of hours service, which is hosted via Angus, and we take a fair share of that one, as well as the highlighted cost pressures that we've already highlighted in terms of care at home. The care at home obviously directly links back to Lynn's comments and that significant improvement in whole system performance across the health board and health and social care. So obviously we've got much improved performance in ED. Our delayed discharges, our unmet need, unfortunately it does come with a cost though, and a lot of that cost is sitting within this driving our overspend. So it's just highlighting that one, albeit we fully appreciate the improvements in terms of performance that we're seeing across the system, but also for individuals who are impacted and either waiting in hospital or waiting for care packages. So again, that's one of these difficult decisions in terms of balancing the financial position and monitoring and trying to maintain the standards that we've achieved recently. So again, it's a quick whistle-stop tour through the paper. If there's any comments, I'm happy to take any feedback or comments or questions.
I'm going to ask myself my own question here. I was going to ask, I've got a couple of people that want to come in, but I was going to ask Christine, what is the projected position for the financial overspend for mental health up till the end of, do we know up to the end of March 2024? Have we any idea of what the indicative overall overspend will be, and therefore what would our, and that's the first question. The second is, do we have a recovery plan for the mental health overspend, and what would be our indicative share of that?
Is this for the inpatient mental health part of it? I think Dave probably wants to jump in with this one. I can see him looking.
Thanks for that. So the inpatient mental health position, as far as we understand, is around about £5.2 million overspent.
Now, is that year end? Is that going
that would be the projected to the year end. Right. As of now, we do not have an agreement across the 3 IJBs, the 3 councils, and NHS Tayside around how that will be kind of supported by the year end. So that discussion is ongoing. As far as any kind of liability that would sit for Dundee, we do have kind of particularly earmarked kind of reserve that could be applied against any share of that. in terms of money that was provided to us by NHS Tayside, I think two financial years ago, to support sort of pressures like this. So we would be covered for anything, any liability that may arise as far as that's concerned. But at the moment, we don't have, we've noted in the paper that the discussions are still ongoing around that in terms of that kind of particular solution. So that's the inpatient mental health side. There's obviously kind of the wider elements of mental health in terms of community mental health services, etc. As well. So, so that's where we're at the moment with that side of things.
Okay, thanks, Dave. Okay, I've got Jim McFarlane, and then you can put your hand now, Dave, unless you've got something else you want to.
I was coming on something else, but it's fine.
No, I'll take Jim first, and then I'll bring you back in, Dave.
Okay, thanks both for the paper, and for Christine and Dave for it. It was just the issue around local government pay settlement, and obviously it's just, I know it has been kind of recently, but one of the kind of big factors in that is that there's now meant to be a pathway to a minimum wage of £15 an hour by 2026. And, has there been any work being put into that at this stage, or what's the plan locally to make sure the proper resources are in place for that to meet that target?
So in terms of that, Jim, I mean, I need to check in terms of where we are with our own kind of staff members in terms of either council or NHS, if anybody falls into that kind of still continues to fall into that category. In terms of it, so aligned with the kind of £12 an hour for all adult social care in particular, that would be something that would be kind of driven at a national level through Scottish Government. That kind of increase kind of up to that minimum level is obviously without additional resources that kind of health and social care partnerships, unless we get additional resources, that's obviously really challenging for us, because it means we'd have to make savings elsewhere to kind of fund that commitment. If it's going to be a legal requirement, obviously it's something we have to do. So we would be looking for sort of national government to kind of try and work through that particular policy and provide the funding to implement accordingly.
Okay,
thanks. Sorry, that's an interesting.
Jim,
yeah, I mean, Dave, thanks for the response. But it just seems that although that agreement's in place, there still seems to be that debate whether the Scottish Government will actually provide the funding for that. I get that they will provide the funding on the health side, but it seems again it's just that disparity and inequality that exists there, that pay awards in health are properly funded from the Scottish Government, but local government isn't the case, even when there's that agreement that's set in place, and I think, and I'm not expecting you or anybody else here to kind of, settle that thing, but I just think that these are part of the debates that then need to be fed up through all the structures there, that, if we are a health and social care partnership and you're all trying to work together, it does seem, looking from, from my point of view, as kind of one side getting treated a bit differently from the other, and that just causes all sorts of problems even in the workplace.
Okay, I think we know your comments, Jim. Don't think we can't solve that this morning. But Dave, did you have another point you want to come in? Because I'm
so
time. It's 10.
I know. Sorry, I wouldn't. I'll not attempt to answer kind of Jim's point there. That's kind of a more a political one for us to answer on that one. So just to know, in terms of kind of in addition to kind of Christine's kind of overview, is we have got an ask to provide a financial recovery plan in line with the integration scheme. So in terms of what the integration scheme says, when we project an in-year overspend, we need to kind of first of all look at a financial recovery plan, and then we look at the kind of balance and reserves to kind of fund that. Now, given that the kind of position has kind of deteriorated kind of from kind of previous report to this one, we've kind of now really sort of kind of triggered that. So a lot of the work that Christine talked about that managers are doing just now in terms of kind of reviewing their kind of spend and kind of looking at discretionary spend, etc., will kind of form part of that recovery plan. But just to say, we'll bring that back to the February IJB in terms of what that looks like. From our perspective, given the conversation that's taken up kind of quite a chunk of this morning about performance and impact, etc., then we would not be looking to kind of implement a kind of recovery plan that results in a significant impact on, for instance, delayed discharge, etc., because it's just it's counterproductive, if you like, on that basis. So, but we will produce something that will come back to you. I will always maintain, though, that for this year we still have reserves to kind of support us, and I think I'd rather use that position rather than impact on direct services for now. So just to kind of provide that overview.
Okay, thank you, Dave. So what we're asked to do is note the content of this report and instruct the Chief Officer to develop the financial recovery plan for the current financial year, which will go to the IJB in 2024. I think that's a kind of requirement of the IJB that we have to produce this recovery plan, albeit it's not really got much time to recover, because if you produce a recovery plan in December, you've only got to the end of March to get things moving. But anyway, that's the requirement of the committee. So if everyone's happy to accept that, then we can approve the report, note the content, and the recovery plan would come to the February meeting. If everybody's okay with that. Yep. So that concludes item number 13. Item number 4, sorry, Ken, did you want to come in there?
Yeah, Pat, just before we go on to the final lap, which will only take 30 seconds, I wanted to say a few words on the occasion of your passing.
Hopefully not my passing, Ken.
Well, we'll get that reworded then.
Yeah.
But yeah, I first met Pat at an NHS board meeting about 4 years ago, pre-pandemic, when she was sat next to me. And I remember really taking to Pat and thinking that she was a breath of fresh air. And over the 4 years or so that I've known Pat, she certainly proved to be that, both on the board and here, first as vice chair, I think. Were you ever vice chair? I'm not sure. No, you weren't.
A couple of weeks maybe, Ken.
But anyway, your time on the IJB, you've really shown your absolute commitment to improving health and social care services in Dundee, and I think that's been recognised by all. It's very much appreciated. Really sad to see you going, because that's a big job you're going to in Fife, and I'm sure all of the other members of the IJB here in Dundee wish you all the best. And I'll probably contact you after a wee while to see how you're getting on.
Yes,
So,
absolutely.
have a great Christmas. Enjoy your time in New Zealand, and good luck in your new job.
Thank you so much, Ken. That's so much appreciated. Thank you. That's lovely. And Vicky's got her hand up as well.
Yeah, you're not getting away that lightly, Chair. So, unlike Ken, I've known Pat for 30 years. And some of you will know Pat was actually the trainer at Management Development Group when I entered into NHS Scotland as a National General Management trainee. So you could say she's got some responsibility for the post that you see me in now. But I was always very struck by just how glamorous and knowledgeable Pat was back in the day. And clearly that stayed with her until now. So it was delightful for me a few years back to know that Pat was joining NHS Tayside and was actually coming over to provide both the chair and vice chair of the IJB. So I'd be really sorry to see you go. And I've enjoyed reconnecting with you, enjoyed working with you again. But the good news is Pat's only going to Fife, so it's just across the water, and she'll be joining another one of the management trainees from that year, because Carol Potter, who's currently the chief exec in NHS Fife, was one of my colleagues. So it looks like those you trained back in the 90s, Pat, have all come back round full circle to work with you again. So thank you very much, and I hope you really enjoy your challenges and opportunities in Fife as well.
Thank you very much. It's been a great privilege to be the chair of this IJB, having been a student in Dundee, came here in 1974, fell in love with Dundee. Well, I was from Paisley, so you can understand why I fell in love with Dundee. I remember the train pulling into Taybridge Station and thinking, wow, this is beautiful, this is gorgeous, I love this. I had my daughter in Dundee, I got married up there, had my first child up there. She was born in Nine Wells. She went back as a medical student and they said to her, oh, you're from Glasgow? And she said, no. She said, I'm frae Dundee. She said, I'm a Dundonian, I was born here. So a lot of sentimental attachments to the city, a great city, it's a great place to be. And I wish you all the very best for the future, and I shall be picking your brains, Vicky. I'll be phoning you up saying, we've got this problem and that problem, how do you deal with it? And hope to steal all your good ideas and take them to Fife. So thank you so much. It's been a real privilege to work with you all. I wish you a happy Christmas and a good new year. Thank you. Bye.
Thank you.
Bye just now. Bye.
We didn't actually finish the agenda, sorry.
Sorry, we didn't do the attendance sheet, because I should have thanked Ken for standing in for me in my various trips and
My
jaunts
pleasure.
that I've had this year. Yes, I know, and I'm off to New Zealand in January. So if anybody's got anything that's to be added into this, or anything that's been inappropriately recorded, would you contact Arlene? And then suffice to say that the next meeting is to be held on the 21st of February at 10 AM, when Beth Hamilton, who takes over as the new chair, will be chairing that meeting with you. So if you'll give Beth all your support and help that you've always given me, I'd be very grateful for that. And the programme of meetings for the PAC and the audit committee are also listed on the papers. That's the 31st of January. So you'll all be meeting up again the 21st. I wish you all good Christmas and a happy new year. Bye just now.
Bye.
Thank you.
Bye.
Thanks very much, Pat. Well done.
Thank you.
Bye.
Thank you.
Bye, Pat. Bye, everyone.